You, sir. And so because these things are needed to be done later on, but later we don't get time. People are just in a rush to head. So I thought I'll thank people at the get-go. So Mr. Anand, Sushil, Rahul, and the entire BOA team for helping making this event coming to fruition. Of Sion Hospital for ensuring that we could do this meeting. Much gratitude already to the speakers, panelists, and to all those who've gathered here, some of whom have actually bothered quite a bit to just come here. Despite being a working day, quite a few of us have left our clinics and to come to this academic event. I'm certain at the end of 2.5 hours, we'll have something more that we've learned here than we started off with. And a special shout out to our keynote speaker, Dr. Rajeev Muni, for being just as cool in person as his post-op cases are in optos imaging. It's actually a privilege, sir, to have you here in person after a couple of years of some fascinating cases that we've seen on various platforms. It's great that he's given us some time to think, about the rethink Reg RD rather. And I personally like how he's approachable and open-minded in all his interactions and conversations, and that makes learning much more easier. So we look forward to having an engaging meeting, and I'd just like Natarajan sir to just start off the meeting and just say a few words.
Dr. My friend Feroz is here, and he said 6 o'clock. It's already 6:06. So thanks to Harshit for doing everything. I know he still works like a Shankarnetra alumni asking, sir, but I think you have to follow Rajeev. You are our sir now. Thank you. So with this, I think you can start the proceedings.
So I'll ask Dr. Amit to start the proceedings.
It's a brief overview of PNR. For this session, we have our esteemed guest of panelists, Dr. Feroz Patel, Dr. Joining, and and other people also who can pitch in whenever things are needed, queries are raised. Over to Dr. Rohit.
Rajeev. The indications have obviously changed thanks to the work done by Dr. Rajeev Muni and his team. What I'm going to speak is the typical indications which I learned during my fellowship. And we always did thought about retinopexy when the retinal breaks were in the superior 2/3 of the fundus and no breaks located inferiorly. And there was minimal media opacity because obviously we want a very clear media to ensure a good peripheral examination and further laser or cryo, whatever is required. No PVR, no history of glaucoma because IOP can fluctuate, rise, post gas injection, and patient needs to be able to maintain a certain position for nearly a week or 10 days. Now, some of these relative contraindications have come into indications again because of the newer technique, which will be described subsequently. Pseudophakics or aphakics were considered as relative contraindication up to grade A or B PVR, retinal breaks up to 3 clock hours apart, and up to 3 clock hours of lattice. And absolute contraindications were considered if there is inferior breaks or grade C or D PVR, extensive lattice degeneration. Speak about the actual technique. There are a lot of different approaches one can go about. It's about the choice of gas, whether we use SF6 or C3F8, whether we use cryo or laser for vitreoretinal adhesion, whether we do it in outpatient or OT. I believe most of us in India do it in OT for the sterility purpose and medico-legal purposes. And what kind of anesthesia we use, whether it is peribulbar or topical augmented by subconj or subtenance anesthesia. So when we are comparing SF6 with C3F8, we know that the expansion of SF6 is lesser as compared to C3F8. So the chances of IOP rising is lesser with SF6. But the disadvantage of SF6 is it has a shorter half-life as compared to C3F8. And again, when we are comparing cryo with laser, inflammation is more seen in cryo. So when I started pneumoretinopexy during fellowship, we used to traditionally do a cryo followed by gas injection. And in some of the patients, there was vitreous hemorrhage because the edges of the HST bled. And laser has been more challenging if we compare with cryo for beginners. And if there is early cataract, especially the cortical cataract in the periphery. The older break, as I discussed, was to cryo the break. do the typical AC paracentesis where would maximum take out 0.2 ml and inject 0.3 cc of C3F8. Tap, which helps us inject a greater amount of gas. And preferably the gas needs to be injected in such a way that a single bubble is formed, avoiding fish eggs. I will skip this slide because this is what Dr. Rajeev is going to talk about. And follow-up is the key. So I usually follow up the patient daily for 4-5 days consecutively. And that is the time when we do a post-op lasers. And some augmentation by cryo is also advisable if required. Thank you.
Sorry for that. Sorry for the technical glitch. So first of all, thank you very much, Natarajan sir and Harshit, for inviting me to give this very interesting talk on what does literature have to say about pneumoretinopexy. So it was first described by Hilton more than 35 years ago as a 2-stage procedure, and it was proposed, to be a relatively simpler option when compared to the normal scleral buckle. So till date, there have been 2 clinical trials that have been conducted in relation to pneumatic retinopexy. The first one was a pneumatic retinopexy, which was compared to the scleral buckle, and followed by that, it was compared to the vitrectomy in the pivot study. So initially, if we go to the earliest study where it was compared to the scleral buckle way back in 1989, so they evaluated 198 eyes from 7 centers involving 13 surgeons. And if you look at the outcomes, the visual acuity outcomes were very similar between both the arms. So if we see with the scleral buckle, 82% had a good reattachment rate, and compared to 72.8% with the pneumoretinopexy, and the final anatomical success rate was also around 99% in both the arms. So they were very comparable. The visual acuity outcomes, in fact, were better in the pneumoretinopexy group as compared to the scleral buckle group at the end of 1 month, and they were almost comparable with p-value of 0.05 at the end of 6 months. And for eyes, who had a macular detachment for less than 14 days, in fact, pneumoretinopexy had a better visual acuity outcomes as compared to scleral buckle. Even the side effects, like the patient-related side effects of pain, photophobia, diplopia and all, were significantly lower with pneumoretinopexy as compared to the buckles, and the risk of choroidal detachments and myopic shift was higher in patients with scleral buckle. So at that stage, they concluded that it can be recommended for particular indications, what Rohit has already discussed, and it offers advantage of decreased morbidity as well as better post-operative visual outcomes. Now next we go to the pivot study, of which Dr. Rajeev Muni was an integral part, and these are the indications very specific, including a single retinal break or a group of breaks that were located in 1 clock hours, and the detachment located above the horizontal meridian. So if we look at the visual acuity outcomes, the blue line represents the visual outcomes of the pneumoretinopexy group, whereas the brown line represents the vitrectomy group. So it was significantly better at all the stages compared at 3 months, 6 months, and at 12 months. And the visual function questionnaire that was done for that, how are the patients subjectively feeling over the vision. So that was also much better with pneumoretinopexy as compared to vitrectomy. So this is just an overview just of the outcomes of the pivot study, where the visual acuity gain was better with pneumoretinopexy, and even the proportion of patients who achieved more than 70 ETDRS letter gain was better with pneumoretinopexy. The metamorphosia was also much better. So all said and done, both these landmark trials have shown that pneumoretinopexy is much better. But now if we dwell further into literature, so this was a very interesting article that I came across by Chronopoulos et al., where they did a very critical analysis of pneumoretinopexy. And so there are multiple things what pneumoretinopexy is proposed to be. Like, it's a very simple, minimal invasive procedure. But when we are doing pneumoretinopexy, we know that we may have to do paracentesis multiple times, not necessarily a single time. Maybe a repeat cryo also needs to be done. All these procedures, what we are doing are actually unmonitored. So we whenever we are doing a vitrectomy surgery or a buccal surgery, we normally monitor the pulse, the blood pressure, and all these parameters are usually unmonitored. And it takes a lot of time. If we look at how to evaluate these patients post-procedure, so the retinal artery perfusion has to be evaluated at 5, 10, 20, 30, and 60 minutes. Then how about the recovery? So we know the positioning is needed for these patients for at least around 2 to 3 weeks, and we may need to follow up the patients daily initially, maybe for 4 or 5 days, to see how is the response and do repeated procedures. Now, they also did a single operation success rate of pneumoretinopexy, and they went over around 323 articles, and they found that a single operation success rate with pneumoretinopexy, the median was 69%. So most of these patients are actually simple retinal detachments. So rather than seeing that 69% are getting attached, if we do a scleral buckle or if we do a vitrectomy for this patient, the single operation success for these patients would be roughly 90-95%. So we are actually depriving, say, around 25% of the patients from a good anatomical success, at least with the first single operation. Then how about the perioperative mobility? If we look, so the risk of ERM formation post-pneumoretinopexy has been somewhere between 10% to 15%. Whereas if we compare to incidence of ERM post-scleral buckle, it is only around 1%. Even the PVR rate is around 5% with pneumoretinopexy, that is less than 1% or 1.9% with scleral buckle. So the chances of post-operative complications are more with this based on this literature review. So they had concluded that it may have a higher rate of subsequent resurgeries, and in many times multiple surgeries may be needed for patients who are undergoing pneumoretinopexy. So scleral buckle rather than pneumoretinopexy may be suitable for a simple retinal detachment. That was based on the review of more than 300 articles. But just to summarize my talk, as we know in our real world practice, so optimal case selection is very much necessary in order to get a very good, even a single operation success rate. And it can have very good visual acuity outcomes, and it can be superior to vitrectomy in maintaining the integrity of the photoreceptor layers and absence of retinal displacement. Thank you so much for your patient hearing.
So we've discussed all these cases in our group already, the R World group, which we are also fond of seeing many cases that Sir puts upon. I'm just going to share a few insights which I have over the period of 7 months. I've done around 32 cases. The success rate is kind of decreasing with time, because I am trying more and more PNR with more and more patients, even which would not fit into the ideal inclusion criteria, but with the modified criteria that we are doing right now and discussing it with multiple seniors, colleagues, we are realizing that I think it's worth a try. There's no harm in doing PNR. So of the 32 patients that I've done, earlier I had a roughly 80-85% success rate. It's gone down to around 70-75% because I've been more aggressive with PNR, and the results have been very good. So 8 patients have failed. Subsequently, I have not tried gas again. I've always preferred silicone oil as my second surgery, because I need a good anatomical success. So the reasons of failure: 4 patients were non-compliant in spite of agreeing to the position, thorough counseling, a good chair time around 20-25 minutes. Still they were non-compliant because they thought that bas itna ho gaya, and that's it, the position was not followed. 2 patients had smaller breaks elsewhere which were not found during the initial examination. 1 patient had, during vitrectomy, I realized had formed holes because of the laser marks that I have done elsewhere from the break. Like there was a 12 o'clock HST, and around the STQ quadrant there were multiple small holes which had formed because of the laser. So probably a more laser was done which had caused breaks. So just sharing 3 cases which I had. Because I freelance and I have multiple centers, I cannot take very good pictures as Dr. Kumta sir will be sharing after me. These 3 cases, this was a case which had a bullous RD, and the break was not seen, but the configuration made me realize it had to be a superior break. I did a PNR. Day 1 patient was 6.6, inferior SRF, that resolved around, it took 2.5 months for this SRF to go. I just had to call him every week and explain to him that there still can be a second surgery, but eventually we didn't require. I was just monitoring the progress of the SRF reducing from the arcades, and fortunately for him, second surgery was not required. And this was the OCT on day 1. This was a patient which it was almost the 5th or 6th patient that I had. He had a cricket ball injury, blunt trauma, and came with me with a large GRT flap. This was the flap which was over the disc and the macula. The vision was FCCF, and he had already been seen by 2 VR surgeons, and had been advised a typical PPV with silicone oil, as I would have also suggested a year back. So I went ahead, I did a PNR, I injected a large bubble around 0.8, 0.9 ml of C3 I use, and I had to do him a sequential positioning. We started with the temporal, I gave him a right lateral, I lasered the temporal half, I gave him a sitting position, and then I lasered the other half. So 3 days continuously I was lasering him, but eventually he's still 7 months post-op, he's still 6'6" and doing very well. So this was one case that I felt was really very well managed, and as sir point out that the functional and anatomical outcomes both are been very good with PNR. This was a one-eyed patient, a young boy who came to me, who was a very high myope. He had subtotal RD. I could see break in the superior temporal quadrant. I went ahead, this was the OCT pre-op. The view was very hazy because of the vitreous degeneration that he had. I did a PNR, the macula was very well settled on day 1. His vision improved substantially, patient was very happy. This was the OCT on day 1. But 3 weeks post the PNR, I again had fluid, which was very surprising. I didn't know he was, I had given him a sitting position, and if you could see, the bubble was still very well filled because C3F takes a long time to go away. But this was the OCT which I had at 3 weeks. I again gave him a little bit of positioning of a superior temporal, just tilting the head with 3 cushions, and the positioning again worked, and again within 2 days he was back to a good vision, and this sustained. I had to just add a few more laser after 3 weeks of PNR. So very surprising, but this is what happened. This was a case which I had done at a peripheral center. So this patient had PVR, this had 2 breaks both in the temporal quadrant. One was almost touching the 8 o'clock in the right eye, and the other break was superior temporal. I went ahead, did a PNR, again I gave him a little bit of temporal positioning, lasered the initial inferior break, and then a 3 pillow positioning to have a superior temporal laser, and this patient is also doing very good. So the problems that I encountered main was when there is no intact posterior capsule. This is the main problem that I have encountered with PNR, because the bubble tends to then shift in the AC, which I have tried in one patient doing the positioning. It had gone back, but 2 patients still had bubble in the AC. Second is AC hyphema. I have seen pretty frequently. Vitreous hemorrhage, although I didn't have hyphema, but I prefer to do paracentesis. Still I get a very shallow AC. So bleed definitely I had in many patients. Inability to access the break with laser due to capsular fibrosis or media haze. So in patients where the bubble has come in the AC, then it became very difficult for me to laser it. I had to literally do cryo the second day because I could not access the break. And one patient had very dense capsular phimosis kind of a picture. So in that patient also I had to do cryo. And position obviously is the very difficult for the patient. In few patients they are really non-compliant, they complain of a lot of body ache and inability to maintain that position. Last thing is the residual inferior SRF. So one clarity that it's very difficult, I have to keep on calling the patients. One patient, as I told you, 2 months they were religiously coming every week, and I was just monitoring, taking a fundus photo just to document how much the SRF was there. And one in the initial first second, I think I had given up and I did a vitrectomy with oil just to realize that actually the break was covered, but I shouldn't have done it. So these are the problems that I have encountered frequently. So this was one patient where we see the bubble when I was injecting, it just happened to come in the AC, and then I had to do cryo on the second day. So definitely many advantages, as Jay has rightly told before my talk. So I think it's a very important tool. There is no harm in doing PNR. I think in any RD that I see, if it's a fresh RD, if I can see the break, I can make out the configuration, I think I'll go ahead with doing a PNR, giving it a try. Counseling the patient, I think counseling made a huge difference in my PNRs in the initial phase and now. And only inferior 3 clock hours is something that I have not done, and only one patient I have injected a rebubble, which I don't do very frequently. I am a little on the safer side that if it's not settling, let's go ahead with the vitrectomy, and be very vigilant. If you see failure, accept and move ahead with the vitrectomy. Thank you so much.
Surgeon in Shankar Nethralaya as of now. So we are happy Dr. Manohar has supported me because I came and actually argued and wanted to come and teach here. So thanks to Dr. Chaya Shinde for allowing me to be a visiting professor here. Sorry, I'm emeritus professor here. Okay, sorry.
Yes, please.
Guidance and support. We have been doing monthly CMEs and national webinars. So from 2016, our department is doing under BOA and Maharashtra Ophthalmological Society. And also we are doing national webinars once a month. So sir, thank you very much for this opportunity. And I thank Dr. Natarajan sir for getting international speaker Dr. Rajeev Muni here. And all retina specialists are here. So thank you very much, Harshit and Jaideep.
So, before we move on, I'd just like Joshi sir to even felicitate our keynote speaker, Dr. Rajeev Muni. So, can we have you on the stage, please? Can you get the madam?
Who's a emeritus professor over here, Dr. Chaya, Dr. Sujit, and the members of Department of Ophthalmology and the Bombay Ophthalmic Society. I think that once upon a time, probably during our student days, retinal detachment means it was something like given up case and the blindness was ensured to a patient. But now the things have changed, the treatment, the surgical modalities of the retinal diseases in the form of treatment for say proliferative diabetic retinopathy, the detachment, the fragmentation. I was trying to understand what is the new word which has been used over here. So lots of things are being done. Maybe way back it was not available. And I'm sure that with diseased retina also, may not be 100%, but partial vision restoration is possible. And my daughter goes on tutoring me about the advances in the retina and the ophthalmology. So way back it was only a cataract surgery and pterygium, but now the things have become more advanced, complex. And the deliberations done over here, which Dr. Chaya and Natarajan, both of them take very proactive steps, will definitely benefit the younger generation of doctors as well as the resident doctors, I am sure, and Rajeev Muni's inputs will give an international understanding what is going on in the retina, in the rest of the world. So thank you so much for inviting me here. I am an odd man out. I am a crude surgeon, general surgeon and endoscopist. So thank you so much for allowing me to speak over here for 2 minutes. Thank you.
The book Autobiography of Yogananda, I don't know how many of you read, Yogi, Autobiography of a Yogi. So here they had a teacher like Dr. Badrinath, that Swami Mukteshwar. So I am going to, Harshit, you can't bribe me with love. So I am going to give this bouquet to you and the gift to Jaideep. Jaideep, bouquet to you. Hey, photo nikale. I am giving to him. And Jaideep, the gift is for you. Come. Come here. Nobody at home to take it, no? So better give it to Jaydeep. Thank you, Jaydeep. All the best to you. So anyway, I'm publicly telling, when I retire, Jaydeep will take over.
So we'll move on with the sessions now. So can we ask Kumta sir to please give his talk?
So, Dr. Gumta sir will be talking on cases and complication in PNR. So please.
Sir, I'd like to thank Dr. Natarajan, Dr. Harshit Vaidya, and Dr. Jaydeep for the kind opportunity to speak here. Dr. Rajeev started posting all his cases on the group, and we were completely amazed at his results. And all of us, I think, to an extent, felt that there was something lacking in our management, and we were not happy with the way things were happening, at least for some of our patients. So there's a Zen saying that when the student is ready, the teacher appears, and that's exactly what happened. And a lot of us adopted this procedure, and of course, a lot of them were, some of them were very critical, especially on the Delhi Retina Forum group, I think. And I think a lot of that criticism was not justified at all. So, actually, I'm presenting a few cases. Yeah, it was entertaining. And I'm sure, Dr. Rajeev, you will pick up a lot of my mistakes, and I am totally okay with, it's going to be a learning experience for me. So although you have always said that SF6 is the best gas to be used, I have used C3F8 in all the cases because it quadruples in size, and I felt that I needed a larger bubble so the positioning could be more forgiving. And I felt that all my patients have been very, very non-compliant. Maybe it's the Indian patients are not that compliant. That's what I have felt. Of course, disadvantages are that it takes longer to expand and it stays in the eye for much longer than you want. So this is the procedure that I did, 0.2 to 0.3 cc of AC paracentesis, and added 0.3 cc of to that, and I get 0.5 to 0.6 cc of C3F8 gas in most of my cases. Face down position initially, 6 hours and macula off detachments, and 4 hours. Most of the cases, some of the cases were different, and tried to steamroll in some of most of the cases. So I'll just show a few cases. This is a phakic patient, 37-year-old, with a supratemporal retinal detachment, with a cluster of breaks in the supratemporal quadrant, one of which was very large. And so I underwent pneumatic retinopexy, and the breaks were sealed with laser. This is after 3 days, the retina was on. After 2 weeks, after 1 month. So this is the final, you got a vision of 6/6. So there's another patient, which is pseudophakic patient, 60-year-old, with a horseshoe tear superiorly and a lattice degeneration in the upper temporal quadrant with the macula of temporal RD. Underwent pneumatic retinopexy. After 4 days, the retina was on, and underwent laser to the lattice as well as the HST, and did well with a vision of 6/12. So another patient, a pseudophakic patient with 6/24 vision with a bullous, supratemporal bullous RD. There was no break seen. Underwent this, and after 24 hours, the fluid has shifted down, and then later the patient underwent laser. And as Dr. Rajeev had also mentioned that you can do laser to the areas which I think I found a break there. I'm not very sure. But that you can laser in the area of expected break according to Lenkoff's rules. So I've done that for a few of my patients where I could not pick up the break. This is after 2 months, and the final vision was 6/9. So another patient who had a non-dilating pupil pseudophakic with a temporal RD, and there was a horseshoe tear at 10 o'clock position. So underwent pneumatic retinopexy, and this is after 3 days. After 1 month, this patient developed an inferotemporal RD, which was not involving the fovea. So I repeated the PNR, and I could not see any break, but I added some more laser in the area of expected break. And this patient did well. There's another patient, a phakic patient with a clear lens, with vision of 6/9, with the macula just getting involved. Underwent pneumatic retinopexy. One moment. Yeah, there was a large HST at 1 o'clock position. So after 2 days, after 4 days, I found a little bit of fluid here, so I was not very sure that she was compliant. So probably you might criticize me for this, but I put in another bubble. I don't know whether I was right in that. I would like you to point out, where you felt things could have been done differently. So then that fluid also settled. Then laser was done, and there was lattice inferiorly as well that was lasered. So after 2 months. This is another phakic patient with supratemporal RD with 2 HSTs at 12 o'clock at the edge of the lattice, Riven pneumatic. After 24 hours, the macula was on. It's really nice to see the macula on the next post-operative dates.
I was just saying, if you look at the cases, look at the OCT, and it's impressive how well the retina is and how good the integrity is of the outer retina. That's what is most striking, from these cases is when you look at the OCT, as opposed to vitrectomy with silicone oil, it looks very different. You don't get the same integrity.
This is after 3 days and after 3 weeks, after 6 weeks. Vision was 6/12. It's another patient, pseudophakic, with an operculated hole at 2 o'clock position. Retina was attached. And this patient, the hole was sealed with cryopexy because the patient was extremely uncooperative and I could not do any laser. So I did cryo, and this is the final outcome. Now this patient has had fluid for a really long time, and we called her in again just to see whether the fluid had gone, and it hadn't, but it had slightly gone down. So 3 months the fluid has remained. So a few unusual cases, not very unusual, but this was a patient with very non-dilating pupil and temporal bullous RD and break not visualized. So underwent pneumatic retinopexy. After 24 hours, the macula was on except for very shallow fluid. After 3 days, the retina attached. After a week, laser PC done. Again, do you find the laser to be excessive? Because I find that I do a little more laser, because especially in cases where I don't see the break.
I think with pneumatic, laser is your friend. I think doing more rather than less is better.
That's what I find myself doing.
But at the same time, you always want to be cautious to not laser over fluid and overdo it and get micro holes and other problems.
So this was a temporal RD with a HST at 10 o'clock position. And so underwent pneumatic retinopexy, and the patient was positioned like that after steam rolling. And the patient did well, and the horseshoe tear was sealed with laser. The retina got attached. And the vision was 6/18. Then 40 days after the initial PNR, the patient developed an inferior RD with a new hole at 4 o'clock position. So we did a PNR again, and we could laser and attach the retina.
So last one.
Yeah. Okay, I'll just... I think I'll just show you the last case that has been...
You've done a lot of pneumatics.
Yeah, this one.
Okay.
So this was a young patient. I have a minute or so? Yeah, okay. So I'm sorry for overshooting. This is a patient with a 24-year-old myop, very high myop around -20, who had undergone a phakic intraocular lens. And he had a retinal detachment. This was like this. So underwent pneumatic, he was very scared of surgery and didn't want to undergo a retinal surgery. So the next day his macula was on, there was fluid inferiorly. And after 48 hours, the macula was again off. So he promised to do more positioning, and then again the macula was on. And then there were 3 breaks actually in the supratemporal quadrant. One was a linear tear, and there were 2 horseshoe tears. So I tried to do as much laser as I could, and then after 4 days again the macula was detached. The patient was advised surgery, and he didn't want to do it. So then pneumatic retinopexy was repeated, and the next day after the second pneumatic retinopexy, the retina was again attached, and further laser was done. Macula was on. Then 5 days post repeat PNR, again fluid accumulated. and 1 week post repeat PNR, the macula was off. So then this pneumatic I repeated for the third time, and it's after 24 hours, the macula, the fovea was on, there was fluid inferiorly, so except shallow inferiorly, and this is today's picture. The retina was, the macula is on, there is still fluid inferiorly, so I did some more laser. So I wanted to know your input on this case, how the way forward for this patient. So,
yeah, I think I rarely would do a third pneumatic. I think that, we don't want to have bad outcomes after failed pneumatic retinopexy. And after the second separate pneumatic, one thing I'll say, and we'll talk in the discussion, that I have a very low threshold to putting in a second bubble very quickly on day 3, day 2, maybe not day 2, but day 3, day 4, second bubble, and your failure rate will reduce by 50% if you do that. But in this type of scenario where the patient then got a second detachment, I would have done the pneumatic. The third one I wouldn't have done. I think I would have given up and gone to surgery. Okay. Because I think that as we're learning, we know pneumatic works. I think everyone here knows that. It works in certain cases, depending on your comfort level. But what we, with experience, will learn to do is minimize the bad cases, minimize the ones that you're going to get very bad PVR, silicone oil, and the patient doesn't see ever again very well. And I think that's where the experience comes in, is to minimize those types of cases. And I think we learned that with vitrectomy, with buckling as well. And that's my only feedback.
In this case, when the safety clearance is in place, what would you have done then? Would you have done a buckling or would you have done a vitrectomy?
In the third surgery, where was the break again? It was all superior still, right? And it was a young patient, obviously.
Yes.
Yeah, so I would do a primary buckle, of course. Yeah, I very rarely would do a primary vitrectomy for a young phakic patient like this. Yeah.
Actually, there wasn't, because it was protecting the lens. So even if I touched the IPCL, I would not be that worried. So, pardon me? Yeah, chamber was a little shallow because of the IPCL, but still deep, means I could get about 0.4, I think, 0.3, 0.4.
May I pause for a second and we'll ask the panelists to come on the dais and we'll continue the discussion. Firoz sir, please. Yeah, because of the recordings. I have few queries of my own. Also, I would like to ask the panelist, now in terms of the Mumbai as a practice place, how do we go about where a retina surgeon does maximum freelancing? So how to look for a case, because PNR as described by sir is that every time we have to call the patient in 2 days and check for laser if we are able to do or not. Now, most of the times where maximum young retina specialists are, they visit the particular place after a week or so. One place where I go, there is another retina specialist, so we mutually laser each our cases, is one how we do. Dr. Asif is not there, but then at times it becomes difficult. So how to look at it? Is there any other way out where we can do a weekly thing?
I mean, that's a problem. I think that you should be following your own pneumatics for the best outcomes. I think in those scenarios, this is very similar to the US model where people are moving around to different practices, and I think that the cryo-pneumatic makes a lot more sense in that situation because you can treat the tear, and I would select those cases where you can do cryo and where you don't have to do lasers perhaps. And then I think it's better that it can be followed by another physician for the 2 or 3 visits in that first week. Also, having the patient come with you to wherever you are is also an option. And so I do that in my practice. I'm in different locations, and I will ask the patient to visit wherever I am, and they will most of the time. But it depends on the geography and the ability of the patient to move around, so or travel and the expense of that. But I think that if you are only going to see them, one time, and then someone else is going to follow them, I would go to cryo-pneumatic, and then you've treated the break, you're tamponading the break, and it should work. If it doesn't work, your colleague will do the vitrectomy or buckle. And I think that, that this would be my suggestion, yeah.
So one question, one point which was raised by Dr. Jayashet was that he showed a PNR versus SB. Now, there were talks of SB having lot of rates of complication. Now, if you remove drainage as the single procedure, you are almost left with almost nil complications. In that particular situation, SB, non-drainage SB, studies have shown that it is slightly better in terms of vision gain versus PNR also. So if I just saw today a case, bilateral RD, one with a small hole in the superior retina and macula was on. I have a dilemma now. The patient has a vitreous in AC. Now, should I go for a SB? Should I go for pneumatic with vitreous in AC?
How old is the patient? Sorry.
Patient is 55-year-old.
And you said vitreous in the AC and pseudophakic.
In pseudophakic, it's coming from the edges of the pupil.
Yeah. And how much vitreous is there?
That's a blob not touching the cornea.
A small blob inferior, basically.
Small blob in the center.
Center. And the break?
Can see the break, can see the entire retina very well.
And break is superior?
Superior, small flap.
Yeah, I would still try a pneumatic in this case. So I would keep the needle superior when I do the paracentesis. I would keep the bevel away from the vitreous. I would do it under the microscope so I can see what's happening, so that I can assess if vitreous is starting to come to my needle. And the other option is to inject 0.3 cc's of C3F8 with no paracentesis. So don't do a paracentesis, put 0.3 of C3F8, and the pressure will equilibrate after 10, 12 minutes, and then you don't need to go into the AC. That would probably be even a better option.
How would you take this case? Like, I mean, would you do anything differently?
Yeah, one thing which I have done, Rajiv, in the past is to limited vitrectomy of anterior chamber and then inject gas, which would make sense, probably.
Yeah, you were in the setting up an operating room. We do this in our office. So, but that makes sense if you're there.
Another thing what I would suggest is what you said, probably if anterior segment surgeon we are visiting as a facility of fundus photograph, tell him to take images post injection, and probably what Kumta said, C3F8, and what Rajiv said with cryo at the same time would make more sense. The other part, what you said about scleral buckling, non-drainage, is one of the reason of drainage in scleral buckling is to get indentation. If there's a bullous detachment, and if you are going to do non-drainage and just rely on paracentesis, probably one or two sutures you'll be able to take, but not many, because if the moment the pressure shoots up, the buccal sutures would give way,
So the reason I asked is because from last 5 years I am doing, last 7 years I am doing exclusively non-drainage scleral buckles, and my results have been almost more than 95-97%. So I am more comfortable doing a non-drainage, basically because my initial 4 cases I had 2 puckers in the initial post-fellowship period.
You put gas or something?
No, I don't do. No, 276, 277. I select my cases, but then all my non-drainage have been a very good. The only finding which I find is because of non-drainage, maybe some pigments, RP pigments settle in the near the posterior pole area because of when the fluid absorbs.
Like patients what Dr. Kumta showed, the break was quite elevated. You would not be able to cryo it. You will be able to cryo only the base of the choroid. And like what cases Dr. Kumta showed, bullous detachment where breaks are quite lifted.
So then I select for a.
Yeah, it all depends.
I do laser after the SRF is absorbed on the buccal area, once after 3-4 days when the SRF is resolved. But most of the cases I have done is non-drainage.
There were reports in the past of that also. There were many surgeons who used to do it that way, and with very decent results. 8 out of 10 you're looking at all the time, in the way you're doing it, and you'll get excellent result. There's no doubt about it if you're going to do it.
So then in those situations, should we go for buccal directly? Because the reason I'm coming is, the question is, gas causes PVD induction. Now, many times we know that the PVD, the detachment doesn't have a true PVD. So when we inject a gas, it will cause some PVD induction, and we have seen cases where there are different areas of breaks which have happened, or after one area has been lasered, the other area comes with a new break. In that situation, the buccal with the encerclage gives a protection of the 360-degree near the aura, where the maximum traction occurs. So,
Take the final word from Rajeev sir.
Can I make a point? When Dr. Kumta was talking about a lot of laser, I just made a mental note. So, initially, I used to find it difficult in some of my cases when the retina gets attached and through the gas to identify the break and then laser it becomes a little tricky, and then you end up lasering a larger area. Now, obviously, we can't cauterize the break like we do in vitrectomy. When we are inside the eye, when we do fluid air exchange, before doing, we cauterize a break. So after fluid air exchange, you're able to endolaser the break because you've cauterized the edges. Now we can't do that in pneumatic retinopexy. So what I do in couple of cases, what I've done is just that area where the break is, I've done a good fundus drawing of just that area. So I'm aware of the blood vessel and the vasculature. So once the retina gets attached, you can sort of figure out where the break is. Once it's, the chorioretinal adhesion has occurred, you can figure out where the break is and then do a more concise laser. That is what I've observed. Yeah, I would just like to say that I think non-drainage scleral buccal is an excellent technique. We've had a lot of discussion about that. I think if you ask me the two most elegant procedures that we have right now, it's pneumatic retinopexy and non-drainage scleral buccal. They won't be, both of them are not suitable for every single case, but those are the two best approaches to get the best integrity of attachment.
Just I'd like to add one sentence to what you said, Preetham. What I've found that in such situations where once retina is attached, you can't see the break. Probably I prefer to do cryo, because in cryo you'll see the break.
in view of shortness, we are running late.
Just one last question. Have you seen larger amount of facilities?
Yes, 100%. Yeah. So I think the one takeaway from many of the talks was to do your second bubble very quickly on day 3 or 4. And if it's not working by day 5 or 6, move to surgery. In and out, but maximum bubble size.
We started off with scleral buckling as a training in fellowship, and there was a very early exposure to vitrectomy at my time. That time I was doing 20 gauge. Then once 23 and 25 gauge came into the mainstream, that became my main approach to retinal detachment. So my scleral buckling criteria gradually reduced, although my maximum numbers were buckling before. But then gradually, since the era of vitrectomy, the buckling had just a few criterias, and after that the rest were all treated with the help of vitrectomy. And silicone oil was my preferred tamponade. But there were issues with buckling. The inflammation was always there because of use of cryo, sometimes excess use of cryo if there were multiple breaks, and then the change in post-operative reaction because of the buckle, and there was a longer recovery period in terms of the vision. Vitrectomy, though it was more gratifying, but then oil had its own issues, especially in pseudophakics and in multifocal IOLs. The vision binocularly was pretty bad, and occasionally there were tilts in IOL, and the refractive rehabilitation only used to happen only after the oil was removed, and always called for a second procedure for oil removal. So the vision recovery in both these scenarios was more gratifying to the doctor rather than to the patient. I mean, at least in my hand. So I was introduced to PNR with the WhatsApp group under Dr. Rajeev Muni. It was a great learning experience, selfless guidance, one-to-one for each case. And that made me confident to include another option in my retinal detachment. Initially, I started off with simple cases, straightforward HST, my first case which I did. But I had a fluid shift. When you do a buckle, you don't actually see a fluid shift because I do a drainage, unlike. So I don't see any fluid the next day. I feel it's pretty good. But when I did my first case and I saw this fluid shift with a star fold, got me a little nervous if I was missing any break or whatsoever, but this all settled down with time. And then I graduated to started doing much more complicated cases. Initially, I was giving a block. I stopped giving a block now, and then I started doing post-operative laser. This was one of the cases which really interested. Here I had a fluid after about a week, and I realized on examination that my laser was incomplete. Like Dr. Preetham rightly said, that the view was sometimes very difficult through the bubble, but could try to do maximum. Gave in another bubble, positioned again, enhanced with the laser, and then I got a attachment. This was an extremely bullous sardi. In fact, the retina was overhanging onto the macula, even though the macula was on. There were multiple folds. I was not sure whether there could be other breaks also. But I think with just one simple straight bubble, I could achieve a success. So basically, since the inception, I've done about 16 cases, and 70% I have given a PNR approach, given the indications that I have selected. But point to note is that I've stopped doing bucklings now. You know, so the cases, out of those 11 cases, 2 were taken up for vitrectomy. One because of I had missed a break, and the second was, I don't know whether I should have attempted this, sir, but this is my image, just a drawing. So there was a large tear, and these were already pre-lasered lattices. The patient came to me with this. I thought maybe there is just a small nasal quadrant which I could just, put a bubble and position, and I may get away with this. But when I put the bubble actually pushed the anterior flap of the tear, and it elevated this edge, and it didn't allow the retina to settle. So I had to take this up for a vitrectomy approach. I've done much difficult cases after that. I've done 2 quadrant breaks with alternate positioning, giant retinal tears, or retinal dialysis. I've done a case of RD with lattice with atrophic hole and a presence of macular hole at the same time. The retina settled, the macular hole, though reduced in size, is still present, but at least now it makes a very standard macular surgery rather than having an off-retina surgery to deal with. So it has its advantages, definitely. It's a very quick procedure. The vision is faster to recover, and you have much better quality of vision, let me say. The gratification is now there from both ends. And there's no change in refraction. But the issues are there. You know, the frequency of follow-ups are like far too many. And you just live with this statement that you're not done until you're really done. So you just have to keep calling the patient time in and time again. You have to depend on the patient for this and his compliance, the frequency of follow-up and the positioning. And there is an occasional difficulty in post-operative view to do an effective laser barrage. Close observation is always necessary to have a timely approach to vitrectomy, because sometimes it could be just unforgiving. So it is still evolving for me. PNR is my now preferred choice, with the criteria that I'm trying not to do it in the inferior 3 clock hours, with a good view, with a minimal PVR, and a very well-counseled patient. I mean, yeah, ultra wide field photography like seen, definitely, though not necessarily, is a big advantage, because you can pick up far more simpler and smaller breaks. And if you have a facility to admit the patient and to see him on, or your team to see on daily basis, is also an advantage. So I think PNR should be given a choice if anyone is beginning their career here. And thank you.
One of the senior most retina surgeons in Mumbai, and an excellent, his documentation skills are known to everybody. I think he can take back a case from 20 years back also and show it to us. I asked him to.
Coming up that I've made note of, the C3F8 SF6 difference. I think that I'm a very big proponent of SF6 because I like the very rapid expansion. With C3F8 you have to wait 4 or 5 days to reach maximum size. Then you make a decision, is it working, is the patient compliant? You adjust your technique, sometimes you'll add gas. Now you're 10, 12 days in. Like I was saying with SF6, you can know in about 36 hours maximum size. I think that by day 2 or 3, you know if it's working. I then add a second bubble. By day 5 or 6, I've decided if it's working or not, and I've moved to surgery. So I like that it's in fast forward rather than slow motion, because when you leave a retina detached for long periods of time, you end up having problems in some cases.
Okay. Now this is the first case. This is April 23. There was a small hole in the upper temporal region. I did pneumo. Now these are the series of photographs. There was a fluid shift. And on day 2 also there was fluid shift. So patient and I probably lost the patients, and I did vitrectomy and इधर एक लाइट रखेगा दोस्त हाँ vitrectomy, and patient did well with silicone oil and then later silicone oil removal. So probably I thought that I didn't do steam rolling and there was lack of patience. So the patient underwent surgery, because when I was not confident, patient obviously was not confident, you know. Similarly, another patient, superior bullous detachment, 12 o'clock break, pneumoretinopexy was done, there was fluid shift and there was a new break here. So probably, as Rajeev said, probably we could have put second bubble, but I decided to do vitrectomy. Normally I am proponent of gas, so I did vitrectomy with C3F8. Patient did well for 3 months and recovered good vision, but after 3.5 months she developed detachment. Now whether it is sequelae of vitrectomy, whether it is pneumoretinopexy, I don't know. So I did second vitrectomy. I did vitrectomy again with oil, and she had PVR which had already set in. I waited for 2 to 3 months for PVR to settle down, and at this stage I did revitrectomy after 3 months and retinectomy. Retina is almost attached, but as you see here, there is little fluid appearing. So some PVR process is going on. So this case, I don't know why it failed with pneumo and then with vitrectomy, and the redetachment was after 3 months. Now, this is the same patient I showed you. Now, this is another patient done recently, bullous detachment, but now I'm patient, so retina settled well, you know. And I inject 0.6 cc of the gas, SF6 only. This was another recent patient. There was a break in upper nasal quadrant here, mainly inferior bullous detachment, retina settled very well. So I think understanding what you are doing is important. Now this is another patient who had very high myopic, operated for cataract by me 20 years back. Here you see there is nothing. In 2023 she comes with upper small detachment. I did pneumo, it settled. There was a sorry, एक light रखना दोस्त, I am pressing wrong buttons I think. Either I am pressing wrong buttons.
थोड़ा स्पॉटलाइट को बढ़ाना थोड़ा.
हाँ हाँ okay. So okay. So this patient had bubble put, retina got reattached, and there was a fluid appearing here, lower nasal quadrant, so this lower portion. So whether it was a shifted fluid, I don't know. So I just continued positioning the patient. Now this is the OCT through that fluid, and next day retina was attached. But however, she developed nasal detachment. And then I suggested surgery, patient was lost to follow-up. So probably there was a break at 12 o'clock position also. Now, when you look at the photograph, this is one thing with ultra-wide field fundus photograph, that it's not true color. So whether I missed detachment here, had I done OCT, I would have picked up, but clinically it was not seen. But if you see the vessel, the detachment is probably not here, and it's only here, you know. So as we see, there are probably new breaks appearing, or in a pseudophakic eye, there may be breaks we are not seeing. And I think the key to treatment is probably do more laser. Now this was again a similar patient who had undergone vitrectomy for primary detachment. I usually use C3F8 in primary vitrectomy. There was a fluid here if you see this photograph, and there was a break in this bubble. So which I again gave position. This is the break area. The retina got settled again. As you see the photograph here, there is no detachment. However, patient developed another area of detachment. So again, I gave position and did laser to this area. And I think still another 15 days, there is no detachment. So probably these are new breaks or you need to observe them. Now, this is another patient, superior detachment bullous and little inferior of, did pneumo, looked well, had little inferior fluid, just observed. The advantage of OCT is that here we could demonstrate a horseshoe tear inferiorly, and we decided to do buccal. Now, whether this was a missed break or new break, this was a new break because this is the same area about 3 days back. There was no break here and there is a break here. So this was a new break which occurred. Patient underwent vitrectomy with oil and buccal. Normally in pneumo, failed pneumo, I prefer to put oil and buccal also because we want to be doubly sure. And he did well. Now, this is another patient which did extremely well, pneumo done, retina on. However, he had small detachment here and vision was 6, 9 and 6. I did vitrectomy and after vitrectomy, after a week, he had hyphema and things went just horribly bad. And this is what the final view of retina was. So whether it was a failed pneumo, I discussed with this patient with Rajeev and he told me that maybe during vitrectomy, I might not have induced PVD, but this patient is about 62. So I don't know what went wrong, but this patient things just went out of control. And now this is the last patient, pneumo done by our friend here. There was a tear here in the nasal quadrant at 4 o'clock position. The pneumo failed, and this was a horseshoe tear which was not covered probably or which did not settle. So again, I wanted to be safe, so I did buccal, oil, and this is the hole which was lasered well, and I thought the job was over. But after 10 days of 15 days when I saw, patient had redetachment and this was bullous. This was probably, I think now it must be because of the high buccal, there was a bullous detachment exudative like thing, and there was PVR which was setting in. And I thought I would just observe this detachment because there's no point in hurrying up when PVR is there and there was no break. So we just observed this detachment and right now it's only probably tractional element which is remaining and the rest of retina is almost attached. So probably I would wait for another 2-3 months and then operate this patient for PVR, Now whether this is failed pneumo or pneumo failed because of the PVR what patient had, I did buccal which was high, so whether there was a transudate element also and PVR continued, I don't know. So this is the final picture of that patient. So to summarize, I feel pneumo is a good procedure for simple retinal detachment when patient can maintain appropriate position. There's a learning curve for patient and surgeon. Surgeon needs to have patience and patient needs to have patience. Repeated meticulous examination I think is very important. Failed pneumo may not have side effects, may not be true. I don't know whether that statement can be true or totally can be not true. What I feel is that what many of us are not willing for pneumo is because anyway change is difficult to accept. To change, you have to change in procedures, to change in thought, you have to go out of your comfort zone and start something new and which is very difficult. People who are using gas more often for vitrectomy than oil, they know the tamponading effect of gas is much more than oil. So I have no doubt that pneumo can work provided you have adequate tamponade and they would probably switch on to pneumo faster. Thank you for your patient hearing.
These cases that are shown are, retina is still a humbling specialty, and I think we all have cases regardless of if we do buccal, vitrectomy, and pneumatic. And I think that Dr. Parikh made a good point that, and he asked the question, is there any harm of doing an initial pneumatic retinopexy? My personal opinion is that when you do 100 vitrectomies, you'll see these same potential complications in a proportion of cases. And when we look at the literature in large numbers of cases, we do see PVR even with primary vitrectomy. So my response to that would be that in an appropriately managed case, I don't believe the risk of PVR is greater when you do a failed pneumatic and then a vitrectomy versus a primary vitrectomy. The caveat is that the appropriate management of cases that are starting to fail or are not doing well, that they're managed, in a rapid manner.
I think the intervention to, switch and realize that it is not going to work and go for the next step, that also matters.
One thought that has come to me, Rajeev, is that, if you're going to, if especially youngsters are going to master this technique that you have so nicely been teaching everybody, is to develop the skill of peripheral indentation and finding those holes. I think no slack should be allowed over here. If you, as a youngster, really develop the art of indentation all round and be really able to see the aura and be convinced that you're not missing any holes, then I think your skill of doing this technique will get even better and better. I think that really lies the secret.
Yeah, 100%. I think that it's a beautiful technique, and it brings us back to the past where you had to have a good peripheral exam and identify all the breaks, draw them, or know where they are. And let's be honest, many centers, top centers in the US, they don't even examine the patients anymore. They book them for vitrectomy and they do everything in the operating room. Here, there's an art to it, and now we're showing that there's a benefit. When you do a good pneumatic or a good buckle, a non-drainage, for example, and you get a good outcome, that is a better outcome for the patient because of the skill of the surgeon. Vitrectomy is a very routine technical procedure where you follow a recipe, and that's why people are comfortable with it.
Thank you. So probably, because I'm trained by Dr. Badrinath and his training is from Dr. Charles Keepens, and anyhow, I wanted to tell this is the result of my fine art of scleral buckling, and I think I'm calling it a fine art because yesterday I saw a movie I would recommend everybody to see. It's called Annapurni. I think it's Netflix. It's on cooking, so it's about the chef and the India's best chef, and then finally they conclude cooking is a fine art. So I think the same thing is Charles Keepens said, do the least to reattach the retina, and I think that's what Rajeev Muni is doing. And again, you have to also read the Surgical Self-Education by Dr. Steve Charles in his book, Vitreous Microsurgery, and also in my book, The Cutting Edge Vitreous Surgery. I've written the last chapter, the surgical self-education. You have to assess. I think that's what I'm seeing. And I also did a lot of pneumoretinopexy when it came. I met both the father of pneumoretinopexy. There was a tussle between the guy from Rodriguez from Spain, and then he claims he did the vitrectomy, this pneumoretinopexy first, and then Dr. Paul Tornambe from US. Both are no more. And he gave me a book on how he was fighting with America, that he is the father of pneumoretinopexy. But now I think Rajeev Muni is really taking a lead. I'm watching. I don't answer the message. I should, hats off to you, Rajeev. You keep answering all the questions, and many times I feel I should answer, but I'm not doing it. So thanks to you. And still, I don't know why, maybe I've learned adamancy from Charles Keepens, who lived 95, and then Dr. Badrinath, who lived 83. So now I'm still doing scleral buckling. So the traditional surgery for retinal detachment is scleral buckling. And I removed with Dr. Jovanovich. He mentioned a lot of history about scleral buckling. He showed books on Aruga, who wrote the first scleral buckling before probably the Gonin era. And he did that rod encircling. And the reason I'm talking history is I love history as a high story. And I'm part of the museum committee of American Academy, and I gave the controversial talk on scleral buckling, the controversy between Keepens and Custodes, and there was no pneumoretinopexy that time. Anyhow, so we all know I'm saying the retinal drawing, the technique of binocular indirect ophthalmoscopy. This is this particular article. It's stored in Shankarnethala Library, thanks to Dr. Badrinath. And I think this is published in 1946, I think. And this is there, and still good, where you have to do the retinal drawing, which all of us. So I feel In my hands, scleral buckling is the gold standard for uncomplicated retinal detachment, and I think Rajeev Muni's hand and many of you, even though I claim I'm young, and I have the mind to change, as Vatsal said, difficult to feel what you, and if you're not confident, patient will not be confident. So I think you have to be confident of whatever you're advising. So I do what will I like to have in my own eye or my parents' eye. And it's a rewarding surgery for suitable pediatric retinal detachment where PVD induction is a problem. And I remember Dr. Jovanovich commenting that the young surgeons want to do vitrectomy because it's easy, and as Rajeev said, it's like a recipe. But when it comes to the PVD induction and or removing the vitreous, that time you're going to entangle a lot of problem. Even today, vitreous dissection, I was operating a retinal detachment, maybe 4 years old. I was surprised, there was no PVD. It's a 10-year-old child, had an injury 4 years back, and had vitreous hemorrhage that time, and somehow lost to follow-up to anybody, and they came. And the parents are doctors, so really sad. So I had a tough time doing vitrectomy because of PVR I did. So this is a scleral buckling from various old photographs from Shankar Nethralaya, and we can see the textbook diagram of how buckle is done. And the principle of, and that's where George Hilton, I think, pushed the wallpaper. He said, when the wallpaper is off, you're pushing the wall. Anyhow, I think, and that's why it's a misnomer. Scleral buckling is a surgery for retinal detachment, and you don't touch the retina. And this is what we all know. So here, a 79-year-old male with the retinal detachment is 5 days old, and this is the retinal detachment with the right eye 6/6 and the so you can see retinal detachment, inferotemporal with the macula on. So I did a scleral buckling. So this is my standard. I do a peritomy obliquely so that we avoid the horizontal meridian. And then I tag the muscle. I remember 5 years back in a course, Tell It As It Is, where there was a question, if an Hollywood actress comes, will you do a pneumorectopexy, scleral buckling, or a primary vitrectomy? And as usual, as we have here, all the three answers was given. But I said, I will do a scleral buckling because in my hands, I have not seen much squint, even though I remove some buckle. Recently, I removed a buckle for a squint. Anyway, that patient I didn't do, but I have in my hands also maybe 1 in maybe 1,000 is happening. And this is what I do. I started with implant, and now we do this BOP technique to do past the scleral sutures, and I put only in the place where covering the ora serrata to the posterior of the break, which is what Skipens taught us, and I'm still doing it. And I think the reason I've said fine art is, as Dr. He suggested that we have to be a thorough and indirect ophthalmoscopy. I'm sure even for the pneumorectopexy, you have to be a thorough. So this is what I do. I have a scleral flap dissection, but in this patient, by the time I was about to do a flap, already the choroid was exposed. So I do a diathermy and then expose the choroid and do a drainage, and you can see a mild this one, and I don't do that needle drainage, which I know it was exposed. So I make sure I do drain the retina dry, and I'm sure many people who are here have seen my surgery, but Nishikant worked with me, and so this is what I do, again a non-expiational SF6 mixture. The idea is to have a less buccal height. This is what I do. And I've seen hourglass appearance, like if they tighten it, and also seen erosion of a buccal into the retina, vitreous cavity, going through the retina. And I don't know how, there's no retinal tear, but the buccal would have come inside. And you can see when the eye is soft, I give a drug. And I remember reading about injecting a single bubble, which Dr. Skipens has described beautifully, like enlarging one small bubble into a large, and adjust the buccal height. You check the optic disc, the periphery, and make sure the buccal height, what you want is moderate. We don't need a tight buccal. And most of the time, and I use the 240 band all around, and then tighten the. So 6 minutes are over, eh?
One more minute, sir.
Okay. So this is how I make sure the knot is in the center of the buckle, and then I use the, I also done a scleral flap and did the no suture scleral buckling surgery, but I prefer to put one suture like this, make sure it's covered well, the tenons and the conjunctiva, and then I use the glue to close the conjunctiva. So you can see the post-op with the 6/6, and then this is the pre-op and post-op of the same patient. This is another 68 by 6/24 revision. This was the break with the macula off, and then a similar buckling procedure. And you can see the post-op 6/9. And I have follow-up of patients from 84. So I'm actually requesting Saumil and also Rajiv Raman from Shankar Nethralaya to take my patients from Shankar Nethralaya, Bombay Hospital, and Aditya Jodh. And this is the, again, counting figure with that macula off. And you can see the lattice with the break. And then I do a scleral buckling with the conjunctival tissue, and then attach retina. You can see the small gas bubble vision. You can see the post-op, and then this was the, and I always make a diagram, make sure this is what I tell the patient, more than 80% success rate. But most of the time, I think there's a retinal detachment. And I've done a lot of revision surgery in Shankar Nethralaya, but now I do vitrectomy, not revising the buckle. It's a terrible, really a bloody surgery. And so this is how and then thanks to Jaideep, who's with me. I hope Jaideep will continue working and take whatever I've learned from Dr. Badrinath. Thank you.
Thank you.
Dominguez was actually the first one to do pneumatic retinopexy from Spain. And the Americans, like, sometimes they do a lot, they steal the ideas, and so they became famous for it, the Hilton and Grizzard. But Dominguez really did the first, and before that it was Kriesig. In patients where you couldn't do a scleral buckle, she injected double bubbles of SF6 gas for complicated detachments that couldn't be buckled. So she kind of got the spark plug going of that you can inject gas in a non-vitrectomized eye, and then Dominguez started doing it as an outpatient procedure. And Custodes was very important because he taught us that you don't need to drain fluid, which was a huge thing that up to then we didn't know. So that also, he had a big part in that.
And I think Ohm injected the gas in 1911.
Yeah.
That's right. So I think he did it. So I think even Van Graff has attempted something to do with the detachment. So I think it's worthwhile to know the history. So I'm actually requesting the ASRS to have a session on history of retinal detachment. Unfortunately, Kirk Paco died, and he had a wonderful session in ASRS long time back. So I actually wanted the slides, but I'm working with Mark Humayun to have a session on history. Maybe I'll look up, maybe we'll have it in Sweden.
Yeah, thank you, sir. Good evening all. So we all have Rajeev to thank actually for this. Less is more. He's elevated actually retinal detachment surgery from a scientific concept to at an artistic level. So he's really done great. And probably an offshoot of this is that technique that I used to do for quite some time that was heavily criticized had now gotten some form of acceptance because it's based on a similar principle. It's basically conceptual, and I'll explain you how. So my technique is based on the same principle, less is more. When in today's era, people are shifting to more is more, they have the obsessive desire of removing every single strand of vitreous that is there in the vitreous cavity. So my path is going to be the middle path. It's not going to be as conservative as how Dr. Rajeev's is. He does not even use a theater. So my technique, I would call it, and obviously in a lighter vein, Rajeev Muni Plus or Rajeev Muni Ultra or Ultra Pro Max, as you will. So when I say I do limited vitrectomy, please do not confuse it with lazy, shoddy, half-baked, hurried form of vitrectomy. It's not that the vitreous is there and I am lazy not to remove it completely. Limited vitrectomy basically means that I do not induce a PVD in the cases where the PVD is not there. Now, obviously, compared to Rajeev's technique, I do use a theater setup. And yes, I do enter the vitreous and do cut vitreous without inducing a PVD. But basically the essence is, when you see these two diagrams here, this is Rajeev's technique where he introduces a bubble in a formed vitreous cavity without touching the vitreous at all. And he's going to then laser it when the break settles with the air bubble pressure. Mine is Cutting the vitreous, introducing a larger bubble. So make space for a large bubble. It avoids fish eggs because I'm cutting the vitreous. You're introducing under visualization, so you avoid that. You do not have to keep injecting, redoing and following up the patient off and on because you're getting a large bubble to begin with. And fourth thing, it's important to note, I don't drain it completely, don't drain it bone dry. It's drained enough to laser so that the break opposes to the choroid, so much so that I'm able to laser, not full, but I do laser at the same time. Again, that avoids that repeat follow-up issue. So 5th and 6th, my technique also avoids retina receptor and vessel displacement, but it's a gray zone. That's why it's lettered in a gray font. That may be because I do not have documentation for the same. But the essence is that I also tend to avoid post-op PVD and counter traction break, which is theoretically thought of to be the disadvantage of pneumoretinopexy. So limited PPV when we say, or no PVD vitrectomy, the concept is very counterintuitive. How can you have a break in the retina when you do not have a PVD? That is what we've been all taught. So the first sentence, how can we have a retinal break or an HST and an RD without some form of PVD, because PVD is actually responsible for the traction-induced break. Because I believe that these RDs with myopic holes with lattice, for young patients especially, and those with trauma who have a retinal dialysis have no PVD to begin with. The holes are actually caused by tangential or circumferential rather than anterior-posterior traction, similar to how you get macular holes. You get a tangential stretch because myopic eyes are large, and the retina cannot keep pace with the growth of the sclera and the choroid, so it tends to stretch out. And all these holes, note that they do not have an operculum. In holes with operculum, I would believe that there is some form of PVD because there is an anterior-posterior traction, and they are similar to completely plugged horseshoe tears. And I would tread with caution with respect to my technique, because then I do not feel that they don't have a PVD to begin with. They do have a PVD, and I would rather do a complete wit. Another observation in young myopic RDs with holes and lattice, if there is no PVD, there is no hyaloid ILM separation. Very important to remember, and hence there is no space for RP cells to migrate to cause PVR. So when these RDs go chronic, if you've seen myopic holes with lattice grow chronic, PVR is due to RP cells confined subretinally, which is why one gets subretinal bands more often than epiretinal membranes. If you have an epiretinal membrane, again I would feel that there is a component of PVD somewhere there, and I would tread with caution with respect to my technique. In such cases, I would do more is more. I would go and do a complete vitrectomy. So on the right side, there's a slash because I don't do these kind of cases with my technique because there's a component of PVD that is already there. I do this technique where I feel that the vitreous is attached all along the ILM, especially in young patients where the primary pathology is hole and dialysis, where one is normally tempted to do a scleral buckle because we feel scleral buckle is a better technique and not PPV, as what Dr. Natarajan sir just said, because it's a very difficult area to induce a PVD. Even if you do land up inducing a PVD, you do not land up separating completely the vitreous up to the base. Somewhere at the vessel or some other part of the retina, it will always be attached. You will have iatrogenic tears, you will have PVR and redetachments, and also cataract, of course. So, in this PPV, if I were to do an incomplete vitreous separation, because I cannot manage to induce a complete PVD and separate it all the way, there will be some places where the vitreous will be there, and then there will be this retina and the surface of the retina where the ILM would be bared, and that is where the RP cells would insinuate and cause PVR and traction. So if you see this video here, I'll just take a minute. You see how difficult it is to induce a PVD in this young patient. As I'm inducing the PVD, the retina wants to come along with it, and as the last resort, when I try to induce PVD in an attached retina, the retina actually detaches rather than the vitreous separating out. But if I still want to do PPV in such cases, again scleral buckling, I would do the technique of no PVD vitrectomy. So I would not land up with this incomplete vitreous separation and not incur PVR. So it is basically like scleral buckling from outside, but it is pemproniding from within with the vitreous ILM intact. So I feel that buckle in such cases is overglorified when it is actually the attached vitreous that is preventing PVR, and MIVS is over-criticized because no matter whatever the case scenario, as soon as we enter the vitreous, all we are told to do is induce a PVD. So this is a very, very controversial but a conceptual way of thinking. Preferred practice pattern is exactly the opposite. textbook concepts are exactly the opposite. They said the same thing about PNR until very recently. So this is how the technique goes, just this one video. You have this myopic macular hole, peripheral holes, and you do a very minimal drainage. You see as much drainage as is required to just oppose the break to the choroid, and that's it. You do not drain the rest of the fluid that is there, and you allow it to naturally go. You do demarcate it if you wish to, and you can either cryo or laser those breaks. And you introduce the bubble in as much as what the vitreous would allow. It's not a big bubble. It's a bigger bubble as what compared to a PNR. And whenever you are trying to increase the bubble size, you always tend to use a cutter and not a flute needle, because there is still vitreous there. And then you laser the breaks in the retina and just leave it be.
Could you just sum it up some?
Yeah. So that's how I name my technique as minimal limited vitrectomy. But the more apt term would be either hyaloid preserving vitrectomy or no PVD vitrectomy. Thank you.
Differentiation, anti-VEGF. I hope he's not planning to use anti-VEGF for retinal detachments. Yes, sir, please.
I mean, I think Somil, I've seen him present this a couple of times. My one question is, why not just do external drainage, cryo, and a larger gas bubble?
So I have done that as well. In a few cases where I'm not able to get enough of fluid out through the internal break, rather than interfering too much with the vitreous, I've gone with a 26 gauge needle from outside and drained it externally.
Why not start with that? Because why enter if you don't need to?
I want to remove some vitreous, because in order to get that bubble in, and I feel theoretically at least I can get relief from some traction of the vitreous, which otherwise if I would have introduced a bubble in formed vitreous, I would have actually landed up, someone said gas induced PVD, which probably I feel theoretically, maybe, I do not know what the facts are, but it could avoid, because if you're filling gas in a vitreous filled eye, where there is no traction or counter traction, I would not end up inducing a PVD or inducing counter breaks. So that was what my thinking was.
I think we can take this up later, because this could probably be a never-ending discussion there.
USB क्यों नहीं आ रहा है?
Yeah, I would also ask Dr. Paritosh Kamdar sir if he has any comments to make, because sir is on the panel. And yeah.
Dr. Muni, congratulations for your excellent work. Which one? My observation about is I think it's got something to do with the abnormal vitreous. So if we are able to select the cases where we can identify that yes, this is bad vitreous where it's likely to fail, and this is not the bad vitreous where it's likely to succeed, I think our success rates will go up, failures will go down. So do you have any clues to guide us about which are the bad vitreouses which we must avoid pneumatic in?
My personal experience is that I think we attribute a little bit too much to the vitreous and its role. I was in a meeting and I had a debate with someone, and I said that I think it's a misconception that we need to remove vitreous traction. I think we need to overcome vitreous traction. We do that with scleral buckling from the outside. We do that with gas bubble, and then laser we know can overcome the tractional force. Of course, we know that when you only have a retinal tear, you laser the tear and the retina never detaches. So why if that was the case, you would say, well, when you have a horseshoe tear and this patient has an abnormal vitreous and now has a retinal tear, that we should be doing vitrectomy because a laser will not sufficiently take care of it. So my impression is that we need to overcome the vitreous traction, not remove it. But that said, I agree with you that there are cases where it should be a home run pneumatic, but for whatever reason, even a superior single break will not close fully. These are rare, I think less than 5% of the cases. And again, I would go back to the basic principles of doing no harm. When it's not working, move on. And then you won't have the bad outcomes.
I've seen one of your cases can really have no predictability, because if you're going to have a prefixed idea that it's not going to work in this case, you might be just surprised.
Exactly, yeah. I think what we've learned so much is that the indications have expanded. We've expanded the indications tremendously. And now we're all going to gain experience on how to select and manage the failures. I think that this is really an important thing.
Thank you. Let's
of pneumoretinopexy, and on behalf of the sponsors, I'm going to take this talk. But just a bit I would add to my experience of pneumoretinopexy before I go ahead with this talk. It was in 1996 that Dr. Hilton had come down to Shankar Nethralaya, and I was lucky to be trained under him for pneumoretinopexy. This was way back in that time. And when I started my practice, it was wonderful to settle the retina without surgery. And I was really gung-ho about retinal detachment being settled with pneumoretinopexy till I got 4 consecutive failures. And maybe I didn't handle it well, but I ended up losing 2 of those eyes. And that sort of pushed me away from pneumoretinopexy for a very long time. And I think thanks to Rajeev that, these are some stimuluses that you need in your surgical life to pull you back to the technique that can be trusted upon. So this is just a standard disclaimer. I'm basically talking on behalf of ILIA, who are our sponsors today. And you know that ILIA acts on both the receptors, the platelet growth factor, and also the VEGF-A, and that makes it more effective. So this is just a bit of a theoretical talk about how an anti-VEGF works more is basically on its binding affinity, the elimination half-life, the potency, the clinical targets, and the molar dose. And all these are supposed to contribute to the efficacy of the anti-VEGFs. But the biggest but is that these are all on real scientific data, but we really don't know how this actually translates into clinical mode when you really use it. Now let's just compare it with the various molecules that are available. So if you see that there is the way the VEGF binds, and KD is when it dissociates from the VEGF receptor. So lower the KD value, the higher is the binding affinity. So you can see that aflibercept has got the lowest KD value. So it is the highest binding. So technically it should be working the most. The half-life is the amount of time it works in you, and aflibercept has got the longest half-life. So obviously it should work for the most longest time. If you take the potency, that is also the concentration of the drug that is needed for the minimum action. So that is called as the IC50. That is the minimum amount, the 50% of the drug which gives you the highest potency. So if you see that the IC50 is also lowest for aflibercept, and the lower the IC value of 50, that is the more potent the drug. So you can see from this also that aflibercept is one of the most potent of the drug. And if you go ahead and you see that where does it bind, you can see that it not only binds only to VEGF-A, but it binds also to the platelet growth factor and also galactin. Galactins are small molecules which works at mediators for various immune processes that we have, and also for the vascular growth factor. So if you see the summary, we can have that the binding affinity of aflibercept is the most. It has got the longest half-life, and it has got a molar dose which is the highest, and it works on multiple targets, and it has got the highest potency. So that makes it potentially one of the most potent anti-VEGF drugs that is available. So you can see that the VEGF molecule itself, the aflibercept molecule itself is designed in such a way that it can bind to multiple targets at one time. It's got a Fc portion which extends its life, and it works quite potently. So we know that most of the disease processes have upregulation of VEGF-A and PIGF, and since aflibercept works on both, we get a very good and a potent action in these conditions. So this is what actually makes ILIA or aflibercept one of the most sought out anti-VEGF even today, after years after it's been launched, and it remains one of the most preferred anti-VEGF molecules among retinologists all over the world. I'm going to skip this slide and just go ahead to the last part, especially with faricimab coming in. And faricimab is basically because it also acts on Ang2. Now, what happens with Ang2 is, it is supposed to increase the anti-VEGF effect of faricimab itself. So now what Roche, the Regeneron had done is they have with them another oncology molecule called nesvasumab, and that is specifically works on the Ang2. So they had a trial called Ruby and Onyx where they combined Eylea with nevasumab, and they found that actually speaking, the effectivity was not different, and actually that combo drug was given up because the combo didn't work better than just Eylea. And that's the basic comparison. You can see that the Eylea with nesvasumab didn't really work as much better as compared to pure only mono aflibercept, and therefore this particular trial was given up and the combo drug itself was shelved, so it never came into market. So basic point that they wanted to drive in is that whether Ang2 pathway really is much better than anything at all in getting visual acuity gains, and therefore you can see that when you compare faricimab with ranibizumab, there are no real great visual gains, although you can have a longer duration action. And even if you see when you compare faricimab with aflibercept in the TENAI and the Lucent trial, the visual acuity gain is nearly the same, it is not inferior. However, we can have a longer duration of action of faricimab, especially in patients with a higher BCVA, just the last 1 minute, and a low CST and a small lesion size. Okay, so in conclusion, let me go straight to the conclusion part. We can say that aflibercept 2 milligram is already targeting quite a bit of VEGF pathway, so it has got a fantastic potential for VEGF inhibition, and it works fantastically well in all indications like RVOs, DME, and age-related macular degeneration. And the increasing the molar dose of an anti-VEGF agent may have a potential to offer the patient with an extended VEGF, and that's where they are going to have a increased dose of Eylea called Eylea HD that's going to come in with 8 milligrams to be injected, and we have to just see how well it works in the future. Yeah, thank you. Thank you very much.
Do you stress about the lesser success rate and the chance of repeat surgery? How do you manage that?
I think as of now, like we all discussed, you should be as confident as you are with your techniques. So right now I'm still not very confident that all PNRs will work in my hand. So I usually tell them that we'll give it a try before your actual surgery. If it works, we avoid your surgery. So that way patients are more or less inclined to go ahead with that.
So even I used to do the same thing, and I felt that time the conversion rate was very low, because when they hear a word try, many of them just back off from there.
You tell them that a complex surgery is required, and then to avoid that, during the time you get your blood tests and all done, we'll inject a bubble of gas inside the eye, and if it works, we'll not do the surgery.
Quick word from Anupam, sir.
Yeah, sir.
That's a very difficult thing to answer, because basically I feel that you should look at the patient, see his what is his emotional status. There are some patients, like I had one patient who came to me because he was offered Nemo. He was very upset about it. So he was not at all willing for Nemo. So in those type of patients, there is no sense in telling him to opt for Nemo. There are some patients who are scared of surgery. Like one of my patients, he said he can lie down only for 5 minutes, that's all. So there was no option on it. So I did what was possible, and luckily it worked, but I had to do it twice.
I think one important thing is that the patient can feel if you're weak, if you're not sure, if you have a lack of confidence, and I think how you present it to the patient, because many surgeons will have more failures when they're not confident, because they'll give up very quickly, they won't be confident lasering. You have to believe it's going to work, and you really have to believe that, and it will most of the time when you do, like anything in life, right? So today I'm going to talk about a few things in our time. First of all, I want to thank you all for having me. Mumbai is like a home for me, so I come here, and since COVID, not much, but I'm already twice I'm going to be here next year for weddings and different things, so I come all the time. So I look forward to our relationship growing and getting to know all of you more. Today I'm going to talk about understanding retinal displacement, which has really been the stimulus for me to go into retinal detachment in detail. So how do we assess integrity in retinal detachment? We know that you can use it, fundus autofluorescence imaging, to look for these retinal vessel printings, and through all of our research we've now understood that fluid moving under the thin elastic retina stretches the retina. This stretch is what leads to retinal vessels that you see are shifting. And this stretch is what leads to patients perceiving objects as smaller and pinched in. Now, many will say that, my patients don't complain of these findings. The findings improve over time. But we all know that retinal detachment patients, although we can achieve anatomic attachment, don't have the best functional recovery that we would like. And so I want you to hear in the words of one patient. Vitrectomy 14 years ago, and your visual acuity is actually quite good. Like when you're reading the chart, you could see 20/25. Yes. But how do you describe, like if you look at someone's face or if you look at objects, how does it compare between in the left eye versus the right eye?
It seems very much smaller than what I can see with my right eye.
Okay, so if you look at my head, how do you describe what you're seeing with one eye and then the other?
The best way I can explain it is that it seems like the head is 3/4 the size of what I see with my right eye.
So how many of us would want to walk around with one eye seeing 3/4 of the other side of the size of the other eye? And this was a woman 14 years after vitrectomy surgery. 20/25 vision. So clearly we're doing a great job. We all know how to attach the retina, but we can do better. We can improve, and it's because we understand why this is happening. And it turns out in the literature that a substantial proportion of patients complain of these symptoms of metamorphopsia and anisoconia. So all the discussion today was about anatomic reattachment, but now we're moving beyond that, looking at integrity of the photoreceptors and all these imaging outcomes, and this is what's allowing us to maximize the functional outcomes. We have to move beyond my success rate is 90% or 85% or 87%. We all know that all of the techniques can attach the retina. So why are we having this discussion? It's because it's no longer only about anatomic reattachment rate. There's other metrics that are equally or more important, which includes all of these things related to retinal displacement, outer retinal folds, integrity of the photoreceptors. And it's about more than visual acuity. It includes anisoconia, metamorphopsia, all of these things. This is a case that you might have seen before. It brings home the point. A simple supratemporal retinal detachment, single break. After a vitrectomy, you look at the FAF and you see maybe there's some mild retinal displacement here. But in this case, we had the fundus autofluorescence from before the patient ever had a detached retina, and because we were doing something in the other eye. And so we overlaid, and you look here and you can see that the nasal vessels where there was no retinal detachment are completely aligned. The optic nerve is completely aligned. But look at the temporal retina. The whole temporal retina has shifted. It's stretched and it's displaced. This is not a success at all. And we have to change our perception. When you look at the color photo, you'd say the patient had a successful outcome, but the retina is in the wrong position. So recently, we've been doing a lot of research with fundus autofluorescence imaging, and not always do you see retinal displacement on FAF. You might do FAFs on your cases and say, well, I don't see it. But what we've learned is that even when you don't see it with FAF, it's still there. And how do we know that? We have taken cases where we have an OCT image prior to the retinal detachment occurring. Why? Because some patients come in with a PVD, they come in with for other reasons. And what we do is we take the OCT and we use the RPE and choroidal landmarks and we overlay them, and we're able to essentially overlay the entire OCT macular cube. And then we can really tell what's happened to the retinal vessels. So these are examples where the FAF did not show a lot of retinal displacement, but when we use this technique called homography, And you can do this with the Heidelberg en-face infrared image. And when you overlay them and color code them red and green for the pre and post, you can see that even when the FAF has shown negative, it's positive on the homography. I'll skip a few examples, but here's another case, FAF negative, positive with the homography. Another example, it was negative on the FAF and there was mild retinal displacement here. And so what we've learned in these cases is that 100% of vitrectomy cases have this retinal shift that occurs, or stretching of the retina, and that we need to modify our techniques to achieve better outcomes. If you look at this example here, this is a very telling case, and I'll explain to you why, and it brings home the cause of retinal displacement. This is a patient who I did a pneumatic on, and I put a gas bubble in, and immediately this is what the retina appeared like right after the gas bubble injection. When did I take the picture? 1 minute after. How could the fluid all move in 1 minute from point A to point B? And that should tell you that this is all related to the buoyant force of the gas bubble. And if you now imagine, if I told you that the buoyant force that's applied in pneumatic is 3% of the buoyant force applied in a vitrectomy case from a 98% gas fill, how much force do you think is being applied to the retina? And then also think about the retina not as a piece of wallpaper that doesn't really stretch, but as a very elastic, stretchable tissue. And so should we be applying 30 times the force that we need to in order to achieve a retinal reattachment? Here's another case 1 minute after the gas injection. Again, it shows you how the fluid has completely shifted. So what is the mechanism of retinal displacement? We know that there's always some subretinal fluid left behind at the end of surgery. That fluid gets shifted by the large buoyant force. I hope I've convinced you that the buoyant force of the bubble is substantial. And that shifts the fluid and stretches the retina. Anytime fluid flows, take your hand under a bed sheet and you'll see, even if by moving your hand, you'll stretch that bed sheet and that tissue. And so here's another cross-sectional view showing that puddle of fluid that we see so often at the end. Even if we use perfluorocarbon liquid or posterior retinotomy, you'll get this residual fluid, even sometimes not visible clinically, but present on intraoperative OCT. You'll see this fluid shifting. So now that you know this, how would you modify vitrectomy to minimize these risks? What can we do differently? Clearly, 100% of vitrectomies in the traditional manner will have these outcomes. So I'm going to go take you through my journey in how we tried to understand this. So the first thing I thought was, before I understood what was exactly happening, I thought that if I avoid air fluid exchange, I thought the air fluid exchange was the problem. And so and that the gas bubble. And so I said to myself, I'm going to inject this perfluorocarbon liquid in the eye, slowly inject it over 2 minutes, and that will be the end of the surgery. I will laser the tear and close the eye, leave the perfluorocarbon liquid in. I'll come back in a week, I'll take out the perfluorocarbon liquid, and I will have no retinal displacement because I did not use a large buoyant gas bubble, and there was no effect of gravity pushing the fluid. But what I saw was the worst retinal displacement I ever had. And there was no gas involved. And why? Because we realized that if you force fluid to move under the retina in any way, that is, you will get this stretching of the retina. In this case, you need two things to get retinal displacement. You need to move fluid, and then you need to hold the retina in that stretched position. And I did both of them here. I expressed the fluid in one way, stretched the retina, and then I held it in that position with the PFCL, which was absolutely wrong. And this patient had severe symptoms, but I learned what was the cause of retinal displacement, or what we call this low integrity retinal attachment. And so here is just showing you in this specific case that the superior brake actually was attached and closed because I had done a pneumatic, but the inferior brakes were open, and it was that. If you go back to the FAF, you'll see that the vertical vessels are moved temporally and the horizontal vessels have been shifted inferiorly. Everything was shifted infratemporally in that exact same direction where the fluid was being expressed. So with Shankar Netralia, we did a recent study also looking at scleral buckle versus vit buckle for the same thing. And of course, with no drainage scleral buckle, we don't see retinal displacement, very rare. When you do a vit buckle, of course, we're going to see it a lot. But what did we see when we drain? When we drain, what are we doing? Again, we're moving fluid, and then it sticks down on the buckle when the drainage stops. The stretched retina then sticks down, and it's held in that position. It can't relax. And so you also get retinal displacement with drainage in some cases. So now that we understood this, let's think about vitrectomy surgery. How can we change vitrectomy surgery? So this was a case early on where I started doing that I shouldn't move fluid. Essentially, you should not move any fluid when you do these cases. So then we repeated this type of technique, and we did the same minimal gas vitrectomy. So we started with our vitrectomy. These are the type of cases where I would do a pneumatic. I don't do this technique very often because I do pneumatics on all of these cases. But let's say someone says, I don't do any pneumatics. I want to relieve vitreous traction, or, what I suggest is that you do your vitrectomy, you remove the trocars, suture the wounds, but then don't do the air fluid exchange, don't do the full gas bubble that we know are harmful. We now have conclusive evidence that they're harmful. So just do a pneumatic, put a small gas bubble in. In this case, you saw that I marked the breaks. I did the same positioning I would normally do with the pneumatic retinopexy. This is in the clinic. I lasered in 1 minute because it was marked with the endodiathermy, very easy. And this patient had no retinal displacement. And here's another example. So you may say, well, what do you do with inferior breaks and superior breaks, for example? So here's an example where, we had an inferior break associated with the retinal detachment and a superior break as well. So in these cases, what will I do? I'll put a segmental scleral buckle for the inferior break. I'll use a small gas bubble for the superior one. And here you can see, I had put this segmental buckle in. And even though I did a vitrectomy, in this case, I did not get retinal displacement because I didn't move fluid. I didn't drain the fluid. I didn't externally drain it or internally drain. All I did was put a segmental, a vit, and a small gas bubble. So is this? Oh, okay, all right. So here's another example which I think is very instructional. So here's a case. We'll just skip forward a little bit. We talked about the mechanism in retinal displacement. So here's another case where I did a minimal gas, small bubble, with a vit buckle because their patient had an inferior break as well. So here again, you're going to see a very important learning point. So we treated the inferior and the superior breaks with cryopexy. We put a segmental buckle for the inferior break, and I was going to put a small gas bubble for the superior break. So I should get no retinal displacement, right? But I made a mistake. What did I do here? I did a fluid-fluid exchange. I said, okay, well, let me take out some of the fluid because I was nervous maybe it won't fully attach. But what's going to happen now? I'm moving fluid under the thin elastic retina. When is this fluid-fluid exchange going to stop? When the retina sits on the buckle that I put in there. And again, this was probably one of the worst cases of retinal displacement that I ever had. And here you're going to see the FAF showing a very significant displacement in the direction of the fluid-fluid exchange. So I've shown you that external drainage can cause displacement, fluid-fluid exchange can cause displacement, the large buoyant gas bubble can cause displacement, perfluorocarbon liquid can cause displacement when you leave it in. And, I think we go back to the father of vitrectomy who taught us that the retina wants to heal itself, and you probably it will heal if you don't do too much. And I want you to remember this case that taught us so much about the extent of retinal displacement that's there, that it does have an impact on patients. I think it's very important to differentiate slippage from displacement. When you look at retinal displacement, what's happening is that we talked about fluid moving from posterior to anterior. When fluid moves from posterior to anterior, it stretches the retina, and then it causes redundancy posteriorly. Anteriorly. The redundancy will be anteriorly, the stretch will be in the macula. And that's why people see objects smaller. If you stretch a macula, the spacing of the cones is greater. Objects are perceived as smaller. An object is falling on fewer cones. In slippage, it's the opposite. Fluid moves from the anterior to the posterior during the air fluid exchange. When you take out the PFCL, the fluid moves posteriorly. You get redundancy posteriorly. If you have redundancy posteriorly, what are you going to have anteriorly? Stretch. And so in slippage, you get the stretch anteriorly and the redundancy in the macula. That's why you get folds. With retinal displacement, the fluid's not moving from the periphery to the posterior, it's moving from posteriorly to the periphery. And so that's why it stretches the macula and it collects in the inferior region where you have redundancy that we can't image very well. So that's the difference between retinal slippage and displacement. So this is a patient who has 68-year-old phakic male, visual field defect for 1 week, came in and had a GRT. What are we going to do for this? Pneumatic retinopexy. So we did a pneumatic. This is day 1. The retina is attached, and essentially over the next 2 or 3 days, we were able to complete the laser. And you look at the imaging, and you see the beauty of the photoreceptor layers very quickly, and there was no retinal displacement. And I will say that, someone made a comment about pneumatics in GRT. It's probably, on one hand, considered crazy to do a pneumatic, but on the other hand, it's the most elegant way to fix a GRT, because if you do a vitrectomy, not only do you have a high risk of slippage, but you also have a high risk of retinal displacement. So from an integrity perspective, vitrectomy is probably the worst thing you want to do. By doing a pneumatic retinopexy, you can avoid slippage. Slippage is impossible with pneumatic. It just is impossible because you are never moving fluid from anterior to posterior. And so by understanding this, we can realize that we can do the best outcome with GRT. And in fact, when the GRTs fail, it'll fail from the inferior horn of a GRT that doesn't close. And sometimes you can just do a segmental tire and you don't even have to go into the eye. And this has led me to venture into another technique that we've just recently published in JAMA Ophthalmology on in-office suprachoroidal viscopexy for retinal detachment repair. Now, this has been described before, but our technique is different. We do this in the clinic. The patient doesn't enter the operating room, and we don't do any opening. There's no incision. There's no cut down. We take a syringe, which has Helon 5, and we inject it under the retinal break. Currently, this is the best viscoelastic we have, although we're trying to work on developing a longer lasting one. It lasts about 2 weeks. The viscobleb will close the break. And why did I go into this? Because I understood that even with pneumatics, the gas bubble can cause some displacement. And so I wanted to find a technique that was naive to gas. I didn't want to put any gas in the eye. And this is essentially allowing the retina to attach in the highest integrity mechanism possible simply by closing the retinal break. It's essentially a non-drainage buckle without having to do a scleral buckle. So this was the first patient that we published in JAMA Ophthalmology. Was him in the clinic. I had a Helon 5 syringe. I took a 30 gauge needle. I put a guard on the needle using IV tubing. I just made it myself. And I'm looking with the indirect, I'm indenting, and my assistant injected the viscoelastic when I told him to inject. And there's a lot of nuances to this technique, and we can talk about it for a long time, and I'm going to start giving you guys more cases over time. This is a case where I did the viscopexy in the operating room in combination with vitrectomy. So I'll also do it in combo with vit. Instead of a vit buckle, I'll do a vit, what we call sphexy. And this was that one patient that I showed you where the fluid resolved from day 1 to day 2 with foveal reattachment and high integrity retinal attachment. So I just hope I you a sense of my journey from that allowed us to understand this mechanism of retinal reattachment and how gas, although it's been great, has some harmful effects to the retina. And, I think we have to think about these basic principles about simply closing the retinal break. If you just think about closing the break, then what are you left with? Procedures like non-drainage buckle, pneumatic retinopexy, suprachoroidal viscopexy, and I think this will be the future of retinal detachment repair.
Thank you, Dr. Rajeev Muni, for that excellent talk. And I think you came with PNR, and now you're coming up with this. But
Yeah.
it's a wonderful concept, definitely. And even Dr. Nagpal sir used to say, if you could just press your finger at the area of the break for long enough, you'd be able to settle the retina.
Exactly.
And
I
this
think,
is something-
I thought, and that I'm sure that many have thought that if you just hold a Q-tip or something, it'll reattach. And even people have talked about just sandbags and closing your eyes for a couple days and not moving around. And it's all about just closing the retinal break. And why have we gone into, internal drainage, large gas tamponades? Because, we've been sold to do vitrectomy. The machines are there, we buy the machines, we have to use the machines, and when vitrectomy became popular, it became popular from a technical perspective. We became accustomed to the maneuvers, the instrumentation, but there was never a randomized trial that compared vitrectomy to another procedure. There was never an assessment of functional outcomes. There was never an assessment of the imaging outcomes. That was never even looked at. It was just about how can I get the retina from detached to attached. And that is what drove the economics and the interest in vitrectomy. And we all became comfortable. Now we stopped training scleral buckle and pneumatic retinopexy. And now we're understanding that that was probably wrong. And it's going to take time to reverse. And I don't want to sound like I don't believe in vitrectomy. I do a lot of vitrectomies as well. Even for retinal detachment. So, but it's not my first line.
Please
Yes.
go ahead with the next one.
He improved to 6/12, but he was not happy. He says,
Yeah.
he was not bothered. He improved from counting fingers to 6/12, but he was bothered about anisomia.
Yes.
That's why the viscopexy is coming.
That's what made me go into this, but I want to clarify a very important point, that when you have a scleral buckle or a vitrectomy, how often can your patient see at 1 week? Or even at 3 days or 7 days?
So this was at day 4.
Right. So at day 4, what do you see with a vitrectomy with gas? Nothing, right? So what you're getting is a skewed assessment of the patient's complaints because they're describing the healing process at day 4 from a photoreceptor perspective. Whereas with vitrectomy, we can't even assess that until 2 or 3 months when the gas is gone, the silicoid is removed, and so forth. So pneumatic patients actually will complain a lot at day 3, 4, 5, 6, 7. Yeah, my vision's now 20/30, 20/40, but I'm seeing everything smaller and pinched in. And part of it is understanding that the gas bubble, even in pneumatics, is applying a very substantial force, like I showed you. And I'm even rethinking, should I be doing steamrolling? Because there's some preliminary evidence that the face down stretches the retina. That buoyant force on the gas bubble will displace fluid and maybe stretch it, and maybe positioning to the break is better. I don't have definitive evidence on that, and there's pros and cons that we probably don't have time to discuss in full detail. There's certain advantages of positioning directly to the break, which I think lead to a more natural attachment. But if you position to the break and you don't steamroll, as Dr. Parekh showed very nicely, he had a lot of failures. And I think that you have more failures when you do not steamroll. I think when you position to the break, if it works, you'll get a better attachment, but you'll have more failures. So I think that the anisoconia has not been eliminated. We know that from our clinical trials that it's less, 50% less in terms of the severity. Also in terms of the frequency, it's 50% less. And so we can reduce it but not eliminate it. And you're getting a skewed assessment because you're hearing from the patient on day 4 or day 5.
Yeah, let's move on, please.
Okay, so we're going to go on to, and what time is it now, just so I can keep track? Yeah? 8:30. Okay, so we'll move through this. So, you know, I think I'm going to go through some of this very quickly because we've talked a lot online and everything, and I really want to have a chance in the last 30 minutes to talk about the questions, you know, and to go over some of this. So I think we've covered a lot in the amazing talks that have been here. We've talked about laser versus cryo. I'm going to just focus on a few very important points. So one thing people ask is, why do you do cryo, and why not cryo? Why do you believe so much in laser? And this ultra-wide field image is very instructive because it shows us that when you do cryopexy, you do not get attachment of the retina until day 5 or day 6, okay? So you don't get an adhesion, I should say, between the retina and the RPE. When we look at laser and we look at the OCT image, we see that immediately after the laser, there's some adhesion. And this is not a big deal when you're doing a vitrectomy, but when you're doing a pneumatic, it's essential because you want the adhesion to be immediate as soon as the retina is attached. If the patient stops positioning on day 3, if you've done laser, it'll never redetach from that same break because you've already lasered it, just like a regular horseshoe tear. Whereas with cryo, you will see redetachments from the same cryoed break because on day 3, 4, or 5, the patient stops positioning as well. And so I always like to do laser if I can. If I do cryo, which I think is reasonable, I will add laser later. And I think this is one thing that can add to your success rates. When you have pseudophakic small breaks and you cryo them, or even if you laser those breaks, I always assume that there's missed breaks adjacent to those. And so I'll do a sectoral kind of barricade laser. You know, let's say you have a 12 to 6 detachment. From 12 to 3 or 4, I'll do an aura to aura laser because I know that I'm missing some breaks that I'm not seeing. And so that's something that, you know, Ternambi talked about doing 360 laser. I think that's a bit of an overkill. So it's almost like a segmental a barricade laser in the area that I'm interested in protecting. You know, I think that doing a large anterior chamber paracentesis is very beneficial, and you get used to doing that. You apply a lot of force with the plunger. Many people will say, well, there's only 250 microliters in the AC. How do you get 0.5, 0.6? It's because there's liquefied vitreous that comes through the zonules and allows us to get a large AC tap. You've seen this slide. We've talked about the gas, and I'm going to skip through that. The injection technique we mentioned, you want to go halfway in with the needle and then pull back so the tip is barely in the eye, and then inject into an ever-expanding gas bubble. And I always inject minimum 0.6 cc's of SF6. Intraocular pressure, you know, I saw someone mention that glaucoma was a contraindication. Intraocular pressure rises, but it always comes down, and essentially raised IOP is almost a non-issue with pneumatics, as most of you who do them know. And there is no difference between C3F8 and SF6 because as the gas expands, your eye will always equilibrate. The rate of expansion is relatively slow, and our body has the ability to adjust to that. So let's get into some of these cases. Very simple horseshoe tear. You've seen cases like this. We put a single bubble and laser, everything goes well. This is a patient who has lattice degeneration. I laser it immediately before the gas injection. And then here you can see we did an AC tap. We positioned with the gas bubble. This is on day 1. The laser is intact inferiorly. You see the retina mostly attached. And this is at 2 weeks. Now, another very important point that I want to focus on is vitreous traction. Many times today, people have discussed the possibility that a gas bubble with vitreous traction or that can cause new breaks. And so what we did is we looked at cases where there's visible vitreous traction prior to the gas bubble injection. And where do you get this? When you have lattice degeneration inferiorly, which is relatively common. So here's an example. You see the OCT, you see the vitreous pulling on the inferior retina before and after the gas bubble. And what we see is absolutely no change. It's a myth that the gas bubble will cause some sort of crunch of the superior vitreous and pull on the inferior retina. That's an absolute myth. And what we do know, though, is that when you inject a gas bubble into a vitreous-filled eye where there is no PVD, that you will get a PVD over the course of about 1 month. And so when you do not see evidence of a PVD, I believe those patients should be followed a little bit more closely because they will get a PVD. And whether you induce a PVD in a vitrectomy surgery or with a gas bubble, or you do a scleral buckle and 10 years later they get a PVD, whenever you have a PVD, there's a risk of getting a retinal tear. And so you should be following them a little more closely. This is a patient with a bullous superior detachment. It was a chronic detachment, and I hear in India that many patients will present late. So this is an example, 6 to 8 weeks later, and you can see that the patient has very significant photoreceptor loss and had a superior GRT. And with the gas bubble injection, you can see that we've achieved attachment. We were able to laser the retinal break, and the patient had a very good outcome. What about chronic detachments? So this is a patient, Somil, you were talking about doing your minimal vitrectomy here, maybe in this type of case. This is a asymptomatic, atrophic hole, although this might have been, a hole at 10 o'clock. There was a horseshoe tear, so maybe not. In this type of case, we injected the gas, and this was an important point about the residual fluid. In a chronic detachment like that, the bubble will shift the fluid, and it'll take a long time to go away. And in fact, we followed this patient for a while. This was at month 3. You see there was still some residual fluid, and that by month 6 it was gone. And this is important to steamroll these patients to move the fluid away from the macular region, and then in the periphery you're not in a rush to get rid of it. This is another patient here, superior temporal retinal detachment, single horseshoe tear. This patient at week 1 had a very good outcome. So let's talk about some cases. Maybe this is one you would do a minimal vitrectomy on. This is an atrophic hole, no PVD. But a simple pneumatic works beautifully in these cases. Doing a vitrectomy would be maybe not your approach, but a standard vitrectomy, I agree with Somil, would be not a good thing, because what are you doing? You're converting a controlled situation where the hyaloid's still attached, where there's no communication, and you are now turning it into what we call a dysregulated situation where fluid can rapidly come in. So if you do a vitrectomy, first of all, you may not be able to get the vitreous off completely. We know that in these types of cases. And then, not only that, you've now created a communication between the inside of the eye and the subretinal space. And when these vitrectomies fail, we know that they're very nasty outcomes because of those reasons. So a pneumatic retinopexy is a beautiful procedure. You inject the bubble, block the tear, the RPE reabsorbs the fluid, and you laser the break. Here's another patient with a chronic detachment. You see inferior, or in the macula, there's some subretinal bands. And subretinal bands are not a problem as long as they're not causing traction on the retinal break. The retinal break here was superior with no traction. The bubble will close that. And just like when you do a scleral buckle with non-drainage, you can achieve very beautiful attachment. And that that subretinal band will stay there without any issue. Here's another patient, multiple temporal breaks, and here you can see we put the bubble in and lasered all the lattice around and also all the breaks. Another chronic detachment with choroidals. It's a beautiful technique when you have choroidals, because with a single bubble injection you can close the break and you can raise the pressure, and this will allow the retina to attach and the choroidal to resolve. When you have very large radial breaks, you can also treat this with pneumatic retinopexy, but in this case I injected a second bubble because after one bubble it was actually worse, and the second bubble got us over the hump. So here's a patient with a complex pediatric pneumatic detachment. Patient had Marfan syndrome with the subluxated phakic lens, had this kind of chronic looking nasal detachment and inferior detachment. With children, it's all about making them calm, so I was playing his music that he liked to hear, and you just tell him we're just doing one topical anesthetic, then a subconjunctival anesthetic, then an intravitreal injection, and an AC tap. And each one of those procedures we do in children in the office all the time, and it's more about verbal anesthesia, talking them through the procedure. And kids do very, very well with pneumatic retinopexy, and he did excellent. So what about multiple breaks? This is a patient who had multiple breaks, lattice all around, and breaks in attached retina that we lasered, and then we put a gas bubble injection, and you can see. GRTs are a beautiful technique. Pneumatic is beautiful in GRTs because we understand the force of the buoyant force of the gas bubble can be used to our advantage here. By putting the patient face down, gravity unfolds the GRT, and the flow of fluid under the retina will essentially unfold the GRT. So you see 15 minutes after a small gas injection, the retina is completely unfolded, and 60 minutes, you see it's pretty much mostly attached. One day, then I started the laser, and I did as much as the patient could tolerate, and over the week, we were able to complete the laser. So let's talk now about some of the complications. You can have fish eggs. If you see fish eggs, you want to keep the patient face down for 24 hours, and often the bubbles will coalesce. Sometimes you can get subretinal gas, and many times you can express this out from the retinal break, but sometimes you can't. And in those cases, I would go to vitrectomy, and you want to be very careful about how you take that gas out very gently. You don't want to create a larger tear because the gas bubble is stretching that retina, and if you create a retinotomy with your cutter, it's going to create a massive retinal break there. So you have to be very cautious with a flute needle, or very gently aspirate it, or externally remove it. Anterior chamber gas can be difficult. You always want to deal, whenever there's some IOL issue or a sulcus lens or vitreous in the AC, you want to be very cautious. And if you get AC gas, first of all, doing the pneumatic with a smaller pupil is very helpful in those cases. And if you get AC gas, you want to bring the patient back the next day. With pneumatics, if something goes wrong, you never have to do something that day. You always have time to think about it, bring them back the next day. Then with a small pupil, with them sitting upright, you can remove the gas from the AC without decompressing the AC. If you decompress the AC, what's going to happen? More gas will come forward. A suprachoroidal gas was actually what triggered us also to think about viscopexy, because we got a few cases of suprachoroidal gas. Our fellows do them, but they always worked because the patient still positions and the gas migrates to where the break is. It effectively tamponades the retinal break. Here's another example, and it'll lead to attachment of the retina. Prehyaloidal gas can occur in young patients. This is something that we typically will just deal with by keeping them face down. It'll often break through the anterior hyaloid face. In some cases, you have to extract the gas. And there's been reports of it causing giant retinal tears, but essentially this is a 1 in 500 type of thing. We talked about new and missed breaks. I believe that most breaks that are seen after are missed breaks, but sometimes it's possible that a PVD could have been induced and you get new breaks. There was some discussion about PVR and ERM. There's no, in all the randomized trials, there's no increased risk of PVR or ERM or macular hole when you compare pneumatic to vitrectomy. So I'm going to move ahead because I want to talk about some of my failed cases. So just move towards the end here. Yeah, here we go. Okay, so let's talk about the failures, the bad ones, okay? So these are the cases where, things maybe should have worked, or maybe there was no chance they were ever going to work, and it led to a failure. So first of all, how do we deal with failures? So this, I'm just showing you an example of a pneumatic that I thought was going to work, a single superior brake. I very carefully explained the positioning to the patient. They were buying in fully. After explaining this to them, the pneumatic was working very well. I had my usual displaced fluid, but very carefully, you see here, there's a brake down here, okay, that I missed. And so I lasered the superior brake, and there was this inferior brake that I had missed. And so I actually brought this patient into the operating room, and now you can see that when a pneumatic fails, it's not like there's PVR all over the place or they have a terrible outcome. It's essentially the same vitrectomy that I would have been doing otherwise. And here you can see that, it's very simple. We removed the vitreous. I identified that inferior brake there, or infratemporal brake that I missed. We mark it and drain and laser. And essentially this patient had a great outcome, even though the pneumatic, didn't work. So here's a patient, 61-year-old phakic male. This was a more complicated case, had a break at 6 and 6:30. This is not my case, one of my colleagues, or actually no, this is my case. Inferior PVR, and here you see the OCT. We put in, because it was a 6 o'clock break, we did 0.6 cc double bubble, but there was no improvement, and essentially at the end I did a vit buckle and oil, but the patient had a reasonable outcome, not ideal, but it was reasonable. Here's a 56-year-old pseudophakic, fovea off, 1:30 to 7 o'clock, multiple superior brakes, standard pneumatic. I tried everything, gas. On the second gas injection, it went subretinal. Then I had a near total detachment. But I did a simple vitrectomy, and the patient did very well. And I think that when you have a failed pneumatic, I noticed that you guys like to use a lot of oil, but Dr. Parikh mentioned that he's a proponent of gas, and I 100% agree. I think when you have a failed pneumatic, vit gas does very well, and if it doesn't work, or if you're worried about it working, I might add a scleral buckle to it, but almost never would I go to primary oil. In our North American perspective is very negative against oil. We don't use it very often, and so I would suggest a vit gas or vit gas buckle if you're concerned, and silicone oil would be on my third procedure only. This is a case of a GRT that went wrong, 64-year-old phakic male. GRT from 5 to 12:30. I put in the gas bubble and the whole thing kind of folded over, and I ended up doing a vit buckle oil here, or vit buckle oil. This is a patient who, a 36-year-old male, phakic soccer ball injury, had a temporal horseshoe tear, should have done well. But it never fully resolved, and my fellow was managing, and essentially there was a missed break up top at 11 o'clock and it did get better, but then started getting worse again, and we ended up doing a primary scleral buckle and achieving a decent outcome. This is a patient, large breaks, there's a risk of subretinal gas, so we were able to get the gas out and then attach the retina and laser it. This is a patient with choroidals and essentially did not resolve despite everything, double bubble and all that, and I did a vit gas. And so I'm just going to end now on some common myths that I hope we've dispelled. Number one, people say a pneumatic doesn't work because you don't relieve the traction. We've talked about how you don't need to relieve it, you just need to overcome it. People will say it's not a long-term solution because the retina will redetach. We know that from our randomized trials that the risk of redetachment is extremely low after 3 months, and so it's a very durable procedure. People will say that it causes high risk of PVR, but we know that there's no evidence from randomized trials. People will say that it's too many visits. So when we looked at the number of visits in our practice, in the PIVOT trial, there's one extra visit over the course of a year, and this doesn't count all the cataract surgery visits and other things. And this is all for better functional outcomes. The biggest complaint is that the success rate is lower, the reattachment rate. It's 81% in the PIVOT trial cases versus 93%. So what that means is you would have to operate on 8 patients to save 1 patient from needing surgery. And so, why subject 8 people to worse functional outcomes, more displacement, more outer retinal folds, more photoreceptor discontinuity because you want to save 1 patient from needing an additional surgery? It doesn't make sense. And also all the cataract surgery that you're going to have. So I'm going to leave on this case, this graph here, which I think is very instructive. This is from the left side of the graph to the right side of the graph, goes from complex to simple cases. This is the reattachment rate, primary reattachment. So when you do all comers in our practice, this is the difference, 82 versus 93. This is pivot trial. Again, about 12 to 13% difference in our success rates. But what about if you just took a single break, no other pathology? The difference between VIT and pneumatic is only 2%. So even if you're anti-pneumatic and you say that I want the highest single operation reattachment rate, if you should be at least doing it in these cases where there's one single break, because the difference is 88 versus 90% single procedure success rate. But my reason for promoting pneumatic is because of the vision. Even when you have more failures, the vision is always better on the pneumatic group. The blue line here shows the logmar visual acuity. So even when you have failures, you're still doing better with pneumatic in terms of their final visual acuity. And so I'm on the other end of the spectrum where I say I don't care if I have a single operation failure, because what I value more is their final vision. And so I'd like to end on that note. Thank you again for having me here, and I'm happy to take any questions. Yeah.
What is the percentage and what cases especially you see displacement?
Yeah, I mean, the displacement is much less. So we see it in 15% of cases, of fovea off cases. So, and it's, what we're learning is that displacement is not a yes-no thing. It's a how much displacement is there. So the magnitude of the displacement is also substantially less. So it's a step in the right direction, but it is still not ideal because you're introducing gas into the eye. And so, you know, what are the procedures that you can minimize displacement down to zero is non-drainage scleral buckle or suprachoroidal viscopexy now, which is what I'm trying to work on more and more. But that technique also has some pitfalls and risks involved. And so, you know, now I think there'll be 3 good techniques. There's non-drainage buckle, pneumatic, and viscopexy. These will be the ones that will give us the best outcomes.
Now, considering the low integrity retinal attachment that you're talking about, now if you were to do a vitrectomy, let's say, it failed PNR or primary vitrectomy, do you still do the way you were propounding, as in not drain and do a pneumo at the end, so to say?
So those minimal gas cases I showed you would be something I would do if I was doing a vitrectomy as a primary procedure. You know, when you've had one failed procedure already on a patient, it's very hard to do another thing that's a little bit out of the box. And so many times when I have a failed pneumatic, I do a traditional vitrectomy because I don't want to be talking to the patient a 3rd time and trying to, you know, say, okay, well, now we should put a full gas bubble in. So I will do it in some cases where the patient is understanding of everything. But you know, I do think that you also want to get the job done quickly, and you don't want to have multiple failures of multiple different techniques. So, you know, that's why I understand why you guys might put in oil, because you feel oil buckle, a VIT oil buckle is going to lead to a complete, and it will, probably 98% of the time. But I think that the gas approach is better. I think that you'll probably get your 90-95% attachment rate. And if it doesn't work, then I'll just do a quick oil exchange, you know, air fluid exchange and oil.
How do you deal with inferior breaks?
So for pneumatic, we do sequential gas bubbles. So we will always put a second gas bubble in on the 3rd day, and we'll maximize how much gas we can get. When we looked at our double bubble success rate with inferior RDs, it's about 65%. And if you look at the PRO study done with Wills and the big centers in the US, their success rate in phakic inferior break detachments is 65% with vitrectomy. I don't believe the vitreous removal has anything to do with the success rate. It's the size of the bubble. So if I can get the same size of the bubble, I'll have the same success rate with pneumo.
How would the positioning be?
The positioning would usually be on the side. So with 2 bubbles of 0.6 SF6, that's 2.4 cc's maximal expansion, which covers half of the eye essentially. I very rarely would put in 3 gas bubbles, almost never. So 2.6 SF6. So if you want to get even bigger, you can put 2.6 C3F8. But that will cause cataracts in phakic patients. So maybe 0.6 and 0.4, you have to play with it a little bit.
Fair enough. So there was this one more talk which was also very controversial but very thought-provoking. that even inferior breaks, if you position in the supine position,
Yeah.
all breaks are anterior to the equator eventually.
Right.
So when you put gas, and if it tamponades against the lens, so to say,
Yeah.
they would probably better tamponade those breaks than you were to keep them
Yeah.
prone or to keep them on a
so
side.
there's one very important point, is that the maximum buoyant force of the bubble is at the apex of the bubble and not at the periphery. So when you put a patient face up, you're only getting the meniscus of the bubble around the breaks, and there the buoyant force is less. And so that's my concern about that technique. I haven't done enough of those to know. And the other thing is that we all, of course, have the retrolental space and the pars plana region, so you need to have enough gas there. It has to be a big enough fill to do that. But I don't have enough experience with it.
The same thing would apply when you position on the side. If you
Yeah.
have a 6 o'clock,
Yeah.
the buoyant force is going to be much
Yeah.
lesser
Yeah.
because it's the periphery of the bubble that's going to be.
So,
somewhere.
you know, we'll do side positioning on a decline for 5 o'clock breaks, and we'll try to do this to maximize where the apex is. But you're right, you know, 6 o'clock breaks are very challenging.
Correct. So I was wanting to ask you, do you decline the positions
Yes.
patients?
Yeah, we will.
Do you think of doing SF6 C3F8 so that the tamponade, because C3F8 would take at least 3-4
Yeah.
days to expand to its full.
Yes.
And or has anyone
As a
tried?
mixture. As a
Yeah,
mixture of
has
gases.
anyone tried
yeah.
that?
Yeah, so we've tried what we call SF6 with C3F8 chaser. So we'll put a SF6 first, and if it's not working, then we'll put a second gas bubble of C3F8, because we're now knowing that a simple SF6 gas bubble won't do it. And then we will inject the second C3F8 and get a longer and a bigger gas bubbles. But no one's, as far as I know, has mixed the gases. I think it'll dilute both gases, and they will both wear off quicker.
But you have done this way, that first SF6 and then after
Second
2
bubble
days.
C3F8, because I saw an inferior break. I wanted a really large bubble or something like that.
So I have done pneumatic retinopexy in a vitrectomized eye for 2 patients. One was an open globe injury case with IOFB, and 4 months post-surgery, patient presented with a temporal field defect and a nasal detachment, and both cases I had a very good outcome. So what modifications or suggestions you give us in a vitrectomized eye?
There's no difference, except that you'll probably get a larger AC tap because now you have water in the back of the eye. So by pressing on the limbus, you'll get lots of fluid coming out. So you'll be able to put a very large gas bubble. You can also do a fluid exchange in the office. We've done that, where you've probably seen videos where you lie them on their side, you're injecting gas from one side and you're draining fluid from the other. But generally a simple pneumatic, the usual approach will work, and you just go based on the location of the break. I don't change anything in my technique for failed buckles or failed vitrectomies.
In fact, I think post-vitrectomized eye remove works better because you have much larger volume of gas.
Yeah, exactly, yeah. But, again, you have one failed procedure, so, how much bandwidth do you have with that patient to do, again? Exactly, yeah.
Kumta sir, Kumta sir, do you have any questions or any points that you want to add? Or
Rajeev, just a general question.
Yeah.
Biggest enemy of retinal surgery is PVR.
Yes.
What are your thoughts on preventing PVR? Just in general, not only on removal.
Yeah, I think that we're going to enter an era of pharmacotherapy in retinal detachment surgery. So, many groups, including ours, like we have stored samples of over 1,000 patients now where we've collected fluid, and we're doing analyses to try to find ways to inhibit it. We know the GUARD trial looked at methotrexate. We have a clinical trial looking at topotecan. If you ask me 30 years from now, what will we be doing? When a patient presents, we'll be injecting some drug to essentially inhibit the cellular proliferation that's occurring. I think we also will learn from our techniques that some ways, and Somil mentioned this, that there's certain things that we do that are probably not advisable, like doing vitrectomies in young patients where there's no PVD, for example, and trying to do a full vitrectomy. These types of things, we'll go to more minimally invasive procedures, and we will start to use pharmacotherapy as well.
Dr. Rajeev, could you elaborate a little more on suprachoroidal viscopexy?
Yeah, I mean, it's very exciting. I have a conflict of interest because we're now developing a device to make this a procedure that anyone can do easily. The issue has to do with the scleral thickness variability. So if you inject temporally, for example, where the muscles are, the scleral thickness can be 0.5 millimeters. Other places it can be even 1 millimeter, as we know. And so it'll vary based on the location of the break within a patient, between patients. And so you need to have a device that can allow you to sense when you've passed through the sclera into the suprachoroidal space. So I've now done over 20 cases with just my rudimentary technique. And in certain cases, it's beautiful. In other cases, the biggest problem is that I can't get the bleb to form in the location that I want. So temporal, nasal breaks, these are easy because of the palpebral fissure. But when you're dealing with the brow, upper and lower, to get the needle perpendicular to the sclera is almost impossible with the straight needle. And so you need a curved device. You need to be able to sense the scleral thickness to have this as a technique that anyone can do and feel comfortable. Right now, I would say that, it's, I think I'm the only one doing it, as far as I know, and it's still a stressful procedure, I would say. So I'm going to publish more and more about it, though, and I'm collecting cases because I don't want to just come out and say that this is something you guys should try or do, because some cases don't resolve. In many cases, I can't get the bleb where I want it exactly, centered on the break. But I have a number of cases and certain criteria, like temporal horseshoe tears, they do very well with the procedure because I can get to where I want with the needle. So we're going to talk a lot about it, and I'm going to publish more. But I want to have the benefit of having experience with 50 cases, 100 cases, so that I can then really tell you like what are the risks and what are the benefits. Because right now I can show you examples that have worked really well and other cases that have not worked, but yeah.
How do you counsel your patients for viscopexy, particularly given the fact that...
Yeah, it's very tricky. I mean, what I tell them is that this is a new technique that I've done now 20 to 30 cases of this. If it works, it probably is the best possible approach. If it doesn't work, then I would move on to another procedure. And what I do is I do cases most of the time that are acute detachments where I know a pneumo will also work. And so I bring them into the clinic, I try the viscopexy, and you have to be cautious, though. You don't want to go too deep and cause a hemorrhage by putting the needle in the subretinal space. So you have to be very cautious. But what I do is I bring them into my clinic. I will start the viscopexy, and if I can't get the bleb where I want it, I will then put the gas bubble in immediately at that point. So what I tell the patient is that, if I have to do the pneumatic, you're going to have to position for a week and everything. If I can get the bleb in the right spot, you can go to work the next day, which is the beauty of this procedure. Like my patients who have viscopexy literally go to work the same day or the next day. They have no change in their life at all, which is an unheard of thing in retinal detachment repair. So, and if it doesn't work, I then do the pneumatic and I say you have to lie on your side for a week, and this is how I'm doing it in my office, and it's allowing me to do the procedure and to have a salvage procedure right there. In the event that you start to see any, like let's say you've gone too deep with the needle or something and you're starting to see any hemorrhage, I always have a gas syringe ready. So within 1 second, I can inject gas and pump the pressure up to 80 and stop the bleeding essentially. So this is very rare that you would get a hemorrhage like that, but this is what I do to mitigate that risk.
Have you considered relooking at the balloon?
The link-off balloon, I think you still have to make an incision. You have to go to the operating room and do this. I'm trying to do something that you can do in the office with no incision, no surgery, no positioning, and immediate return to work. Thank you, yeah. I'm sorry, I have to go because my family is having a large get-together today and some friends. But as I mentioned, you know, I'm coming. I already know I'm here next December and January for 2 different weddings already. So I'll be here a lot, and I hope to interact with you guys again.
Thank you so much. So joining us, thank you Natarajan sir, thank you Dr. Rajeev Muni, thank you all the speakers, panelists, and everybody who's come here. I'm sure we've taken something out, you know, from Dr. Rajeev's vast array of cases, and hopefully we'll implement them in our clinical practice as well. So thank you so much. And Chaya ma'am, can we have a group photo before we leave? Yeah, please.